give him as much time as possible. Now, he did indicate that 12 o'clock is not an absolute imperative, but if we can concentrate and give him enough time, of course, to answer our questions. So, is it agreed then that we don't go through private business? Thank you. So, I now propose that we go into public session. Is that agreed?
Given the data, Chair, if it's okay with you, I propose that we have a minute's silence or some acknowledgement for Emma Vic Mahuna, whose funeral is on today. As the Health Committee in the Oireachtas, I think it would be appropriate.
And also for those other women who have died.
Absolutely.
But who have not gone public.
And who are on the way.
And on the way, yes. Of course.
But in particularly for the two women, the second woman whose obviously name is in public, I think we should acknowledge the two of them today.
Thank you. Okay, so we'll have a minute's silence in that regard then.
Okay.
Thank you very much for that. Due recognition of the women who have been affected by this controversy. This morning's meeting, we are going to hear from Dr. Gabriel Scally and Dr. Karen Denton in relation to the report of the scoping inquiry into the CervicalCheck screening programme, which was published last month. On behalf of the committee, I would like to welcome Dr. Scally and Dr. Denton to give their evidence. I wish to draw your attention to the fact by virtue of 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to a qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person, persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statements you have made to the committee may be published on the committee's website after this meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on or criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. I would also like to notify you that Deputy Stephen Donnelly is unable to attend this morning because he's unwell, and he has passed on his apologies. So Dr. Scally, yeah. Perhaps I could open the proceedings by just asking you a number of questions. Dr. Scally, if the screening programme, such as CervicalCheck, is to have unavoidable false negatives reported, as is the case with all screening programmes, how can that be fairly and effectively managed without resort to adversarial legal proceedings? The second question is, could you address the issue of the failure to open disclose the audit findings as soon as they became known? And the third is, you did make not a recommendation, but you did state that the Commission of Inquiry was not the best way to proceed, and perhaps you might expand on that. So perhaps you might just deal with those questions first.
Chairman, I don't want to disrupt the meeting, but I wonder, might it be more appropriate for Dr. Scally to make an opening statement?
Excuse me. He did tell me he didn't have an opening statement, but he did say he wanted to make some opening remarks. So, excuse me. Yes. Proceed.
Oh, no, that's fine. Thank you very much.
Sorry.
Thank you very much. Could I just add my regrets about the death of the two women involved this weekend. It's a timely reminder of the seriousness of the problem of cervical cancer in the country. And one of the tasks, I think, coming out of all of this is to try and make sure that this is an increasingly rare event over the next decade or two, and we'll never again, hopefully, see deaths like this within our lifetime, within possibility of turning cervical cancer into extremely rare disease. So I'm very saddened by the death too. One of the it was a great honour to undertake this piece of work and a great privilege to meet very many of the women and talk to them in person, on the telephone and at meetings, and to talk to the relatives of those that have passed on. And I took great encouragement from their help and their support, and what they told me in very, very frank terms often about their illness and about their experiences. And I've done my best to fully reflect that in the report. I should, since I'm appearing in front of an Oireachtas committee, I should apologise, I think, to the committee and to the Oireachtas for taking so long to deliver my report. My terms of reference were quite specific about when it should have been delivered, and I failed in that regard. I hope I didn't fail in too many regards, but I fully admit and apologise for that. As you will understand, that the delay was essentially caused by the extremely poor provision of information in response to our queries and our requests for information, and it took a very long time for us to get that information. And information was still appearing almost, well, certainly to within a week or 10 days of finalising the report. However, I'm pleased to be able to say that we received all the information we requested. We had interesting discussions about that, and we received all the information requested without redactions, and we are unaware of any documents that have been withheld from us that we should have seen. And I'm satisfied that we've had an opportunity to go through the information that we've been provided with in an adequate fashion. So my apologies for taking so long. My apologies also for not having completed the job. As you will know, late in the day, thanks to the efforts of my colleague Dr. Denton and others, we, through our inquiries, discovered that there were serious issues arising about the laboratories to which the slides of Irish women have been sent, and we were unable to complete our inquiries into that and to other matters pertaining to the contracts and the tendering by the end of the inquiry, and we suggested that there is further work that we would do in the near future, and the Minister has agreed to us continuing to finish that. So I do hope that we will finish those very important matters satisfactorily within a short time. Chair, I think you asked three questions about the...
Sorry for jumping ahead of you.
No, go ahead.
The first was in relation to screening programmes in general, which have an inherent false negative reporting built into those screening programmes. How can that be fairly and effectively managed without a resort to an adversarial legal process?
Yes.
And the second was then, could you address the issue of failure to openly disclose the audit findings as soon as they became available? And the third was, you did suggest that a commission of inquiry was not the best way forward, and perhaps you might just comment on that. Okay. To deal with those in order, and they're important questions. I think screening programmes are really unusual in the healthcare world because unlike most healthcare issues, it's not a question of someone who is unwell or feels unwell who is coming forward seeking help from the service. In screening programmes, it's really the health service on behalf of the state is saying, come to us.
And I think that places an increased responsibility on the health service to make sure the programmes are well run, well organised. And that goes across the screening agenda, whether it be colonic cancer or breast cancer or indeed cervical cancer. So I think screening programmes are different in that way. They're also different in that there is a balance between benefit and disbenefit in screening. For example, breast screening is a good example because the very active the screening process exposes some women, and has done in the past, to levels of radiation which are small, undoubtedly, but nonetheless you are irradiating women, and certainly have been in the past pre-digital mammography to a significant extent. But the benefit is that you will detect cancers early. So the benefit outweighs the disbenefit in a well-run, well-organised screening programme. It's exactly the same with cervical screening. A well-run cervical screening programme should prevent up to 75% of cervical cancers, or detect them at an early enough stage for effective treatment. Along the way, however, there is the issue of what happens when the test, the screening slides, do not reveal the cancer or the precancerous changes that may be there. And that could occur for three reasons. One, it may well be that even though the woman has an abnormality, no cells may be present in the slide. So the finding will be that the cells are normal, that there is no problem. Alternatively, there may be cells present, but the person who's reading, or persons, because generally speaking they're dealt with by more than one cyto screener, does not spot an abnormality, and that may be for one or two reasons. Firstly, that it isn't very distinct, or it's a matter of judgment, and their judgment is that there is nothing significant there. Or alternatively, it could be a very plain error, where there are sufficient signs of abnormality, but the person misses it. Now, my own personal view about that, in respect to what should happen, is I think there should be a mechanism put in place where, due to an error which has potentially serious consequences, there should be a mechanism for compensating the person for that error. And it should be done in such a way as to avoid adversarial proceedings, and there should be a system put in place covering, I would argue, all the screening programmes, and immunisation should be dealt with in that way. And in the UK, there is a system in place, for example, for immunisation, where the government has dispersed a very sizable sum of money in compensation to the very small number of people who may be adversely affected by immunisation, in recognition of the fact that immunisation happens for the benefit of everyone, but some people have, for whatever reason, an extreme reaction where that has resulted in disability to a certain level, and that there is an expert view that it cannot be ruled out that this was caused by the immunisation. They may award compensation. My view is that similar sort of scheme would be appropriate in the case of screening. It's exactly the same. We're asking people to come to us to have testing done, and if they're failed by that through genuine error, I think there should be a mechanism put in place to deal with that, and I hope that is what Justice Meenan will be considering, one of the things he might consider doing, but it's outside the remit of our report. Open disclosure. I think if you go back to the review of slides and the way it was conducted, initially it was conceived of as an educational process for the laboratories. So when cases of cervical cancer were known about by CervicalCheck, and we've got to remember that they didn't know about all the cases, they sent notification to the laboratories involved, generally speaking to the laboratory involved, and generally speaking those laboratories reviewed the slide or slides, and in some cases, particular cases which we're interested in, had an alternative reading of that slide which indicated that there were changes visible in that slide that would have indicated a change in treatment. And the process was not designed to generate information to go back to CervicalCheck particularly. It was meant for use by by the laboratories themselves for their own educational purposes, to look at the performance of the laboratory and to the performance of their staff. And although a copy of the report came back, those were not aggregated and they were not passed on to anyone. What happened then was that there was a decision to put those in a structured and ordered fashion and gather that information, and that decision really came about at the time that the Health Service Executive implemented their open disclosure policy. And a member of staff decided, a member of staff heard about it entirely fortuitously, because this particular member of staff had been on working in a hospital, and they still received some emails from that hospital, and they received an email inviting them to come to a meeting about open disclosure. And this person came back to CervicalCheck and said, there's this new thing called open disclosure, and we need to take this into account in what we're doing. So that's how the open disclosure started to happen within CervicalCheck. And of course, we know it wasn't done at all well. Though, as I've made abundantly clear in the report, I find the open disclosure policy and the open disclosure guidelines that were in operation are really seriously deficient, very seriously deficient. And they weren't so much open disclosure guidelines as it was a kind of policy that clinicians were encouraged to disclose if the clinicians wanted to disclose. But the guidelines gave them every chance of not disclosing, made it really easy for them not to disclose. And so it wasn't really open disclosure at all. That's why my recommendations are very plain and simple about open disclosure, and particularly that there should be a statutory requirement for disclosure. Your third point about the Commission inquiry, as you correctly pointed out, Chair, it wasn't one of my recommendations. It was my view. My view is that we were fortunate enough, partly because of the increased time span that we had, to be able to deal with a substantial number of the issues in substantial depth. And I was very cognizant of the view that had been expressed to me by quite a few of the women and relatives, that one of their major concerns was to make sure that the screening service was fit and safe for their daughters and their nieces in the future. And such was the range of deficiencies that I identified that I made recommendations across that wide range to put the system right. And my fear, I think, was that if there was a move straight away to a commission of inquiry, it would further delay the implementation of the recommendations, and it would distract the system, and HSE in particular, from getting on with doing what they should be doing. So, as I said in my forward, it wasn't my forward, and that was my personal view rather than a recommendation. And of course, I wouldn't have made it a recommendation, because that would have been usurping the right of the Oireachtas to make that decision for themselves, and I have no business making a recommendation to the Oireachtas. They're perfectly capable of making that decision for themselves.
Thank you very much, Dr. Scally. I'm now going to introduce the members of the committee. Deputy O'Reilly, are you ready, or do you want to settle for a minute?
That's all right, Chair.
Yes, of course, yes. We'll go directly then for 7 minutes to Deputy Alan Kelly.
Same 7 minutes you had yourself, Chair. So just a bit of a joke. Dr. Scally, very welcome, and Ms. McEntee and Dr. Denton. I thank you for your work. was embarrassed at the fact that you felt you needed to apologise about timelines at the beginning, because that was unnecessary, because your work is excellent. One of the best reports we've seen in these houses in my time anyway, especially in that short space of time. I have loads of questions, but I'll prioritise them for the chair. And some of the questions relate to your report. I've had a lot of discussion with you already, so I don't want to go over them. In fairness to you, you've been quite accessible. But I have some questions regards the future as well and where we're going. I think that's probably where we need to go. First things first, let me just say that as regards the report, the most important thing, bar none, is that the recommendations are implemented as soon as possible. I think we all agree on that. That's the baseline we should be working on. And let's take that as, as what our priority is. Implement the recommendations. And everything else is subsequent to that, as regards priority, okay? Because it should be all about protecting this generation and future generations is our #1 priority. And I think that's what the women who are affected and their families and the patient advocates have as their priority as well, in fairness to them. And I've spoken to them numerous times, as you know. Okay, so my questions relate to the following. I want to drill into, and this is partly our fault as legislators, the terms of reference you were given. Okay, it didn't include, and there is a lot of commentary on this issue, and I think journalists and politicians need to be quite careful sometimes about, because language is very important here. And sometimes there has been kind of a use of language maybe which isn't necessarily accurate. But as part of the actual terms of reference, you weren't asked to actually go in and investigate what happened in the 221 cases as regards the labs themselves. I believe that's something we probably left out. I'm not sure if from a timelines point of view you would have been able to do it anyway, but it's just something that didn't happen. So there's an RCOG review that's going on, but let's be clear about it. As regards the investigation of their labs and what happened in relation to the 221 cases, or whatever the number is, because it's slightly more, I think, that wasn't part of the remit. But I'd like to ask you, when we outsource, or indeed insource, but particularly outsource, work like this, there are contracts in place. As part of that, there is built-in reviews. As part of these contracts, there will be built-in reviews using organisations like HICWA. Why, when it became aware of issues, the HSE didn't go and drill in to what was happening here and investigate each of the cases? Why didn't that happen? Will it ever happen? Will we ever find out in each individual case to go in and drill into the detail as regards the people who were looking at the slides, the fact that they were misread, and that wasn't brought forward to the top? Why didn't that happen? There were meant to be regular inspections according to the contracts, which I've looked at. Didn't happen. There were 5 inspections, or 8 over 8 years, and in those cases those inspections did not, or did say there were issues, but they were never followed through on. That was a failure. Why didn't that happen? Sorry for all these questions. There wasn't an inspection since 2014. 2014. Was that acceptable? So I really want to know, I mean, in relation to the errors, and I very much welcome, and it was probably the most important finding, that the labs appear to be statistically in line with international norms in relation to their findings. But how do we know that that's corroborated in these 221 cases by the follow-up investigations in the individual cases? You follow what I'm saying, right? And you couldn't get into that detail. So we've reviewed that the labs are in line with international standards, but we don't actually, in relation to these 221 cases, have proof about that or what happened. And why do we have a scenario whereby this wasn't investigated at the time, and the consequences of that, which we all know about today? So that's a group of one question. You can follow through on that. I'll just list the others because the chair will chop me down otherwise, just because I won't get in for another hour and a bit. Second question, very quickly. Are you absolutely...
One question, wasn't it?
Yes.
Okay.
With four components. But it's probably, dare I say it, it's probably the most...
You've 1 minute left.
It's probably the most important question. The second question is, and very quickly, are you absolutely certain you've got all the information? I mean all the information. Because I noted that you said in your introduction you're unaware of any documents. That doesn't mean, or information, that they don't exist. In relation to accountability, I still read the Postcovus minutes, which I helped provide to the committee once upon a time. In relation to accountability, within the HSE, as regards the screening programme and who was over quality assurance and who was actually over it, we need to have a process to deal with that, and I'd like your comments on that. And finally, when it comes to and I think actually we need somebody who's actually going to be a management person over screening, which doesn't fully exist at the moment. And finally, when it comes to the clinicians, which I think as regards the public was the most amazing revelation in this, how clinicians were behaving, some clinicians were behaving in relation to how they were communicating this. What form can we pursue in order to lance that boy? Because the public needed lanced. It was a watershed moment in Irish healthcare as regards clinician-patient relationship. They're my three areas of questions. Thanks.
Okay.
Thank you very much, Deputy Kelly. Dr. Scally.
Yes, maybe Dr. Denton will help me out on the slides, and she's been assisting to some extent with the putting together of the ARCOG review. But your questions are very apposite questions. 221, and you hinted there may be more, and I think that is likely. I mean, we must go back to the way this review was run. It was entirely unsatisfactory in that they only looked at the cases of cervical cancer that they knew about. So they didn't get, as happens in breast cancer, a full data set of all the cancers, all the cervical cancers from the cancer registry, which is the most complete. They ran an alternative register of their own, and only ones that they heard about or were notified within the screening service. Those were the only cases they knew about. So that is, not a good basis for a review, and it doesn't give you the kind of population data, Deputy, you'll understand, that would be able to say over all of the cervical cancer programme in the country how many cases there were where there were slides that were wrongly or differently interpreted post a diagnosis of cervical cancer. So there was a really big flaw in the beginning of the whole thing. The design of the whole thing was wrong. In terms of us having the ability to go and look at those slides, well, firstly, what...
There's a misconcept of it that's happening.
The way in which, even the way in which the reviews that CervicalCheck asked for, which resulted in all the information that has been so contentious, that was deficient as well, because they left it very much to the laboratories themselves to decide how to review those slides. So we're entirely dependent on how they conducted that. And one of the problems is, and I dealt with it, I tried to explain as best I could, the problem of review bias. That if someone is presented, particularly a very experienced cytopathologist, presented with a slide to look at from someone they know has got cervical cancer, they will pay a lot more time and attention at looking at that and find more things than would be found by a cervical screener looking at it within a very fixed time span within a whole batch of slides. So you will almost inevitably, if you subject slides to that degree of scrutiny, end up with more abnormalities detected. I'll let Dr. Denton deal with that. And it is really difficult then to go back and review under exactly the same circumstances what happened. Now, the ARCOG review is as close as we are going to get to that fully objective analysis of the slides, and it may yet take some time, and they may not get permission from all of the women to look at their slides.
But it's bigger than the slides. That's my question. Why wasn't there an investigation done at the time when they knew there was issues? Like under any contract, in any piece of work.
Sure. I don't think that they were surprised there were issues and that there were cases where there was a relook at slides produced a different interpretation because of the nature of the screening test, because there are false negatives. So they wouldn't have been surprised about that. And you've got to remember that for all that it was badly done, it was an unusual initiative in the screening world to do that. And they must get a modicum of credit for having actually decided to look back, even if that look back was done very badly. You asked about QA, and I completely agree. I find the whole approach to QA extraordinarily unsatisfactory. As I said at the beginning, screening services are absolutely dependent upon a very, very tight QA process because of that balance between benefit and harm.
It's frankly non-existent.
And if you don't have it, you're not far off the mark, I think. And certainly, as you pointed out, from 2014, not to have a QA visit. And I'm not sure whether that's worse than having a QA visit and then not following up on the findings of the visit. It's hard to know which would be worse. And then, if you even look at the internal workings of CervicalCheck, as we laid out in the report, the QA committee, which met regularly and had an external chair, but they were almost blindsided about what was happening in terms of the CervicalCheck review or audit, as they called it in the later days. And although there were, I think, 7 iterations of the protocol for conducting this review, none of which were particularly satisfactory in my view, they were never reviewed by the QA committee. So not only was there a deficiency in the QA externally of the laboratory service providers, but there was a deficiency in terms of the functioning of QA within CervicalCheck. And part of that, and you know, all of those areas of oversight, the fact that there was in the entire 10 years, there was one meeting of a medical advisory committee. One meeting of a medical advisory in 10 years. And there was never a cytopathologist actually employed in the programme. And yet the base science that we're talking about, the reason we're here today, is about cytopathology. So there was a serious deficiency in the staffing, in the QA at all levels. Can I ask Dr. Dent if you want to add anything about the 221 and the look-back issues?
Yes, so the direct answer to the question about the 221 is that we were not able to look into them in any more detail. We did find some documentation about the CervicalCheck executive management team's response to some of the earlier findings of the audit in 2015, when they wrote to one of the laboratory providers with queries about recurring patterns that seemed to be being detected. And that's covered in our report. But again, they didn't follow it through. They said it would be followed through in the QA visit, which didn't happen. So there was some attempt to look at some of the women who will be within the 221. But again, it was there hasn't been any collation. There has been no pulling together of the audit results. So there wasn't actually anything for us to look at in terms of trying to break that down. Now, I do think that the RCOG review will be helpful in that respect, although it may well be that quite a number of those women don't give their consent to participate in it, which might limit its findings.
Yeah. Can I go on to the other bit? I should say that the minutes of that Colposcopus meeting were very helpful, and the comment about the Medical Advisory Committee kind of it also goes for that. That was the only meeting in the 10 years of CervicalCheck's existence so far, the only meeting of the lead colposcopists. They had an annual educational meeting for the colposcopy community, but meeting with those group of lead clinicians, that was the only time it happened. The colposcopists did not feel part of CervicalCheck, even though CervicalCheck funded them via the hospitals, and they were working often in clinics with CervicalCheck branding on them. They did not feel part of it. They had been given no role or input into the development of the review or any of its 7 iterations, and they felt quite alienated from the whole organisation. They then did not like the notion that they were going to be expected to front up and talk to the women about the results, and it didn't go well. Absolutely didn't go well, and some of the behaviour was terrible, absolutely awful, and that was why I put that front and centre of the report, because a lot of those attitudes have no place in medicine, and it would make any doctor ashamed, I think, to hear some of those comments. On the other hand, there was some disclosure that was done well. And as I pointed out in the report, open disclosure can be done well, and it was done well in the Wexford incident, and the external review noted that it had been done well. So it wasn't as if it couldn't be done well. There was evidence of it, that it could be done well. But in a lot of these cases, it wasn't. And how do we change that culture? Culture change, a big thing. But working through the colleges, and some of the colleges are very interested in making a shift. I'm quite clear, however, that that's not sufficient. Medical Council wants to make a shift. I'm quite clear that's not sufficient. I think I would look myself to the Oireachtas and the Patient Safety Bill to make it quite clear that open disclosure is not optional. You know, the policy's made it entirely optional up to the doctor, and it must no longer be optional. And that's it. And at the end of the day, there will be, I hope, a legal requirement on professionals to be honest and truthful to patients. They deserve no less. No less.
Cooperation. Just a question on cooperation. That was the short question.
Cooperation with.
You said in your
cooperation, yes. Yeah, indeed.
Unaware of any documents.
Yeah.
So you certain that you got it.
As you'll have gathered by now, I tend to phrase things very precisely. I am not aware. There are documents we would like to have still around the contracting. We would like to see the original tenders and the.
So you don't have them.
We don't have them. And
why not?
Because in an unusual exhibition of efficiency. They were shredded in keeping with the policy to shred things after 10 years. In document management, that's about the only example of efficiency I came across. But we will be hunting for those contracts and tenders from the organisations who submitted them. We will be going and see if we can rebuild all that. But there is more to be done around that whole area. I'm not at all content with the accreditation issues. I'm not at all content with the multiple places to which slides were sent, and their inability to provide us with proper information about that. So there is information that I'm still after, absolutely. Absolutely.
I'll come back again. Thank you.
Yep. Now, Deputy Louise O'Reilly, thank you.
Good morning. Good morning to you all, and thanks very much for coming in. You talked about open disclosure and the need for legislative underpinning. I absolutely welcome that. People had the opportunity to vote for that twice in the recent past. They didn't, but I think that the unfortunate events will really put a focus on that, and the hope is it's a little bit regrettable actually that it would take legislative underpinning, but if it does, that's fair enough. Would you be confident that the paternalistic attitude, some of the descriptions of how the women were spoken to, I'd love to be in a position to say I was wildly shocked by them, but as a woman who uses the health service, I wasn't. Indeed. So, unfortunately, and that doesn't reflect well on much of the good work that is done by people within the health service, and that's very unfortunate. Would you have any confidence that we're going to be able to address that and that we can indeed change that? And I'll group the questions because I know other people who want to come in. With regard to the outsourcing and the governance and how all of that happened, I mean, I do remember at the time when the decision was taken, it was a purely political decision. There was no clinician advised that that outsourcing should happen. It was a purely political decision, and at the time when the Minister was questioned, she outlined the fact that it was good value for money, but nobody ever said there was a good sound clinical reason for the outsourcing. But with regard to the governance, so when it was outsourced and then re-outsourced, and you talk about the Medical Advisory Committee not meeting and the fact that there's information not available, so let me see now. In relation to the QA visits, you expressed surprise that at the level of quality assurance, and that it is not in line with best international practice. So presumably best international practice would indicate that the person in charge, someone in charge, would have sight of the slide or would have knowledge of where the slide was, who was looking at it, and what the results were. But there appears to have been slides sent to the States to one site and then outsourced to another site. And I know everyone says Honolulu, and we all, it seems a bit of a holiday destination. People don't associate that as a centre of excellence for medicine or indeed for laboratories. But how can you have confidence that everything was in order, or how can we have confidence that everything was in order when they don't apply the ISO standard, which I would understand to be a standard, if you will. And so we don't know how many were outsourced. We've asked this question a few times, okay, and we've asked, the first time we asked the HSE at this committee, the impression was given that we'd have the results, was on a Wednesday obviously because one of our meetings, the impression was given that we'd have the results by Friday, that it was really simple. They'd just flick a button and they'd give us the breakdown of exactly what labs were doing what work. And now we don't have that. So it's entirely possible that while on average we might be in line, there could be labs that are out of line. So the lab in Honolulu, for example, we don't know that, but the lab in Honolulu could be out of line with what would be considered international best practice or international norms, and we have no way of knowing that. Have you tried to ascertain the figures in relation to what slides went where, who was looking at them, and how, whether or not there are any outliers on that? Because we've asked for that information and we haven't been given it, unfortunately. So what we wanted was a detailed lab-by-lab breakdown so that we could have a look. You know, I mean, I'm not comfortable dealing with averages. As a colleague of mine used to say, if you've 1 foot in a bucket of boiling water and 1 foot in a bucket of ice, your 2 feet are wrecked, but on average your temperature is fine. So averages don't really tell you anything. We would like a detailed breakdown of each individual lab, and I'm just wondering if it was possible for you to get that. With regard to the contract governance and the shredding of the contracts after 10 years, I too was quite taken with the efficiency. As someone who knows the HSE fairly well, they wouldn't have a massive reputation for being efficient, but they certainly were in this. Is it not possible to get copies of those contracts from the laboratories in the States? And if we have them, can we examine them and see how the re-outsourcing, because that's the thing that concerns me, is not so much that there doesn't appear to have been a very deep and meaningful relationship with the labs in the US anyway. But even notwithstanding that, there was no relationship with the labs that they were then subsequently outsourced to. Thank you, Chair. So
Thank you, Deputy O'Reilly. Dr. Scanlon.
Thank you very much. Dr. Denton will answer some of those questions about the laboratories. Just to assure you, we will be pursuing that. It is a complex area, but we will absolutely be pursuing precisely that sort of information that you request.
Sorry, Chair, but in the absence of that information, is it not a bit premature to express confidence in the process?
Well, that particular provider hasn't been providing screening services for some time. We're talking about going back now to 2013, I think was the last time CPL provided services, and we've no evidence as of yet of any other similar behaviour by any other company, but we will be pursuing that. But nonetheless, the questions still need to be answered as far as CPL is concerned.
Yeah, because up to 2013 there was no evidence that CPL was doing it, but they were, so I think there's a lot we don't know.
Yeah, so up to 2013 there was no evidence that was known to anybody here in Ireland that CPL were outsourcing, and that in fact includes a period when a QA visit was undertaken in 2014 when they were outsourcing. Staff from Ireland were there on the premises in Austin, and it wasn't apparent to them. Now, whether that's because it wasn't disclosed or we don't know the reasons why, but it wasn't picked up during that QA visit. So when myself and two colleagues went to that laboratory, we asked a direct question and we got a partial answer, but they said they were unable to give us exact numbers, but they may have sent some to Florida and to Honolulu. And subsequently, it turned out that they did have an exact number for how many samples had been sent to those two laboratories, which they gave us later. And I think that has been our repeated experience, that if you ask a direct question you get a partial answer, and then there is accurate data there somewhere, but it has sometimes been quite difficult to get. So we are going back in a couple of weeks' time to try and establish exactly what you're asking for, the exact numbers of samples that were sent to, subcontracted to which laboratories, which locations. But I do have to say that many of the locations that they were subcontracted to no longer exist, and in fact many of them were very small, so we can't do a sort of a full review of what those services were like, because they're literally no longer there.
And there's an added complexity in that in some cases the first screen was carried out in one laboratory and the second screen of the same slide in another laboratory.
Yeah, the definition of a laboratory is not what you might perhaps think it to be. It turns out that it can be one screener sitting in a service that provides other services, perhaps blood tests or histology results, and then the pathologist is sitting somewhere else. So we do still have some further inquiries to make around the governance and accreditation of all these services.
And sorry, none of those inquiries were made by the CervicalCheck service or by the HSE. There's no documentary evidence that anyone asked a direct question, even if they were only getting a partial answer. No?
We're quite convinced, because when we learned of this, we kept it very much to ourselves and chose the opportunity when we discussed it with HSA to make sure that we did it face to face with the staff, and it was quite clear from their reaction that this was a complete and absolute shock to them, and it's extraordinarily disappointing on all sorts of grounds. But we will be I can't stress enough, we will be pursuing this, and we will be pursuing it rigorously with the same rigour as we've displayed in this report, and we'll be providing you with as much information as we can possibly get on that. I can assure you of that. If I could go on to your other question about Deputy, you said you were sorry that you had to, felt slightly sorry that you had to resort to legislation for disclosure. I don't think you should feel sorry at all. I think there's nothing wrong with legislating that patients should be told the truth.
No.
I think
what I was trying to say was I'm sorry that clinicians would need that, and that some doctors would need that, and I think that reflects poorly. But if it's necessary, it should be done. I'm also sorry that deputies in the House voted against it, but you know what? They'll probably vote in favour of it the next time. It should be good.
One of the reasons why it is a good thing is not just because it will compel people to disclose, but it also provides a protection for those who know about something that is going wrong and are able to say to their colleagues and to their bosses, perhaps, you know, I'm legally required to do this. Yes. Even if you tell me I mustn't do it, I'm legally required to, and I think that protection shouldn't be underestimated. Yeah, no, Changing the culture is going to be difficult, and you're quite right. I've heard account after account from women with experience of either working in or as a patient who say that that the words of the women and the relatives, which are deeply unsatisfactory in terms of the comments of the doctors, are not atypical of their personal experience. Even women doctors working in obs and gynae say that they've been been the subject of paternalistic and unhelpful comments during their career. I mean, there is a tendency. There's a lovely quote that from the Mid-Staff's report. Robert Francis wrote that into the Mid-Staff's inquiry. And he wrote, "For all the fine words printed and spoken about candour and willingness to remedy wrongs, there lurks within the system an institutional instinct which, under pressure, would prefer concealment, formulaic responses and avoidance of public criticism." That strikes me as being just about perfect. I think that culture will change. I hope that the change in the gender balance in medicine, which is coming through in force, will help change that as women occupy more and more senior positions over the coming years. And I think there is a job for the colleges to do, and there is a job for the Medical Council to do. But I'll be very pleased if the Oireachtas does its bit this time round.
Thank you.
And there was a question in relation to the data coming from each laboratory. Was there a difference between one laboratory and the other?
Yes. We've given what we can in terms of the data from the laboratories in the appendix to the report, and you're quite right. Averages are only averages, and they're 50% of laboratories will be above our average and 50% will be below. And the question is really what is the situation in terms of the slides. And of course, one of the good things about the contracting is that some of the quality standards that were demanded by the Irish contracts are higher than the US standards in terms of the limit on the number of slides that screeners can look at. But and I know Dr. Dent on her visits has been looking at those screener records to ensure that they are accurate, but we are very reliant on the information that we are able to attain. And there are a couple of laboratories, as Dr. Dent says, which are gone.
And was there an issue that some slides from colposcopy clinics were also going mixed with slides?
Yes, very unsatisfactory.
Screening slides.
Yeah, so that's one of my... I agree with you that there's a problem about looking at averages, which is what the programme has tended to do. Now, there do superficially appear to be differences in the rates of certain categorisations from the different laboratories. But actually, the problem is that that's very difficult to interpret, and there could be perfectly legitimate reasons why that's so. And one of the things that makes it particularly difficult to interpret is that the data that CervicalCheck collected and collects still includes the samples taken from colposcopy, who are women largely who are already known to have an abnormal smear. So that will put the rate of abnormality up significantly, and it then means that the proportion of the slides that come from colposcopy actually determines the inadequate rate for that, or the abnormal rate for that laboratory, which obviously is is not satisfactory. So that was why one of the recommendations related to altering the data specification to exclude those samples. And there are a number of recommendations around improving the quality and robustness of data, allowing linkage into other factors that we know will influence the rate of abnormality. And if those are all implemented, then that will give CervicalCheck a toolbox where they can make meaningful comparisons between the laboratories. And that should very much be a priority, I feel. And it may be then that it turns out that there are differences that require further investigation, and that might, they might indicate a problem, but they might not. But actually, we can't even, or CervicalCheck can't even start to have that discussion and that consideration until they've got robust data to be working from in the first place.
Thank you, Dr. Denton. So now, Senator Colm Burke.
Yeah, thank you very much, Dr. Scally, and to your team for a very comprehensive report, and I think it deals with all of the issues very well, and in fairness, a lot of work done in a very short period of time. I think everyone appreciates the work and the report that you've presented. Could I just ask in relation to the whole issue of people being identified with cancer and the clinicians dealing with them would have been aware that they would have already gone for and would have received results of smear tests at an earlier stage. Did it not occur to frontline staff that maybe we should go back and look at the previous smears that were taken? And was there any kind of concerns raised by the frontline staff at any stage over the period of time to the central management system of CervicalCheck? And you said earlier on that there seemed to have been a disconnect between the frontline people and the central management. For instance, when you're referring to that, did you ever look at to know were there people who were involved in CervicalCheck on a frontline basis who might have dropped out at some stage earlier on because of their concerns about central management? And is there any documentation indicating that there were concerns raised at a far earlier stage, even before the audit was done? The second issue in relation to the number of cases where the audit was done on, and there was an audit, it was decided to do an audit, the frontline staff weren't aware, as I understand it, that the audit was being done. Why was that information kept from the people who were dealing with patients? Why was it the information kept from them, and it was only at a later stage that they became aware of the audit and the results of the audit? And then the other thing that I want to question is the time period between people being identified with cancer and when the smear was earlier done. Are there some cases where there might have been an all clear given, say, even 6 months earlier or 12 months earlier? We've heard some cases where mistakes were made in the reading of smears not once but twice. So that raises a very serious question as regards when the same patient ends up with a smear being misinterpreted on 2 occasions. The other issue that I want to check with and about when you take the number of people we have in this country and the number of clinicians at frontline, for instance, you take in obs and gynae, I understand we have about 135 consultants in obs and gynae in this country when all the reports indicate we should have 180. And this issue now in relation to the number of people working in the front line at the moment, have we a sufficient number? And if we don't, what is the sufficient number on the basis of the ratio compared to other countries? Should we have a lot more people dealing with it who have the expertise, and what do we need to do in order to get more people in so that we can provide a far more comprehensive service and to make sure that the same errors are not made again? And the other issue is about the whole education process in relation to, this is not it's not going to give an exact result every time, that there's still a failure in the system, no matter what system you introduce. For instance, you take, say, as I understand it, womb cancer, cervical check won't identify womb cancer. And I understand at the moment, I was talking to a clinician recently who was speaking that there is a huge increase in this country in womb cancer because it's, as I understand it, is related to obesity as well, that there is some connection. I'm not clear what it is, but there's a higher incidence of womb cancer where there's obesity. And like the whole education issue on this hasn't been as comprehensive as what we need to be. And I'm just wondering, what would you do in relation to getting information out there as regards making it available and making sure that the people who, I suppose, have a higher ratio of risk, in other words, that have a greater risk, that information is given to them at a very earlier stage. So they're just some of the issues, but it's just in relation to the ratio of when cancer was identified with people and the time gap between they've been given an earlier all clear, and I'm just wondering, is there any information done on that, identified in that yet?
Okay.
Thanks.
Very much. Senator Burke. Dr. Scally.
Thank you very much. That's a very group of questions. I think between the two of us we'll try and provide you with some answers, Senator. Were the colposcopists aware? I do believe they had some awareness that there was a review going on in terms of notifications to the laboratories, and particularly when it began to be more structured, because when they were looking back at the cases, they, although the bulk of the, and there's a nice breakdown in the report, and a very clear breakdown in the report, that although the bulk of the cases where review was needed concerned cytopathology, there were also cases where there were possible failings in colposcopy or in the administrative systems, and so the colposcopists would have known of something was going on around that. I think the major problem was that their connection and engagement with CervicalCheck was very poor, very poor. I logically expected that there would have been routine meetings after these were very important people in the whole process of the cervical screening and looking after women whose smears were abnormal. And I would have expected that there were regular meetings. After all, CervicalCheck was funding, or the health service was funding those clinicians to work for CervicalCheck as part of the screening program, and there just wasn't that engagement with them, and they certainly weren't involved in the construction of the review and the audit process. But perhaps more tellingly, we didn't see any clear evidence of cytopathologists involved in this, yet cytology was at the heart of what they were trying to review. Do you want to say anything about the colposcopists?
So, I suppose one comment would be that colposcopy is a subspeciality of obs and gynaes. So we haven't looked specifically at the numbers, but I would just point out that the number of colposcopists, accredited colposcopists, is very much smaller than the total number of consultants in obstetric and gynecology. I do understand that there are pressures on the workforce in terms of seeing all the women in a timely fashion, but that wasn't specifically part of our workforce. I would agree with Gabriel. The most important thing is that they were not engaged with the programme. They weren't having any sign-up to management meetings. They weren't involved in drafting policy, and I think that's fundamentally why they were disengaged. But actually, the number of individuals involved is quite small. It's a lot less than the number you're quoting for.
That should be an issue that should now be looked at in relation to going forward, that if we don't have the required number of people at the front line with the expertise, then that's an area that we need to focus on. And the other issue I asked is about, were you aware of people who had been in the service who had left the service because they were unhappy?
I'm not aware of colposcopists who left because they were unhappy. It may well have happened. Certainly, at the time of the outsourcing of laboratories, there was clear evidence of cytopathologists being extremely unhappy about that. The issue about the overall numbers, workforce planning, was not part of our remit, but I think we made it quite clear in the report that there needed to be a workforce review in relation to the cervical screening programme to make sure that it was properly staffed and had the proper access to the expertise that they need at the centre. And one of the most important recommendations is that there should be a national screening committee, because the means of making policy decisions around the screening programmes, including issues about the staffing, is quite unclear. And there does need to be a national screening committee that can advise with expertise and independence about the programmes, about new programmes, and about any changes or modifications needed to existing programmes. And that does not exist, which is why it's one of our key recommendations. The issue of education is extremely important. I take that two ways. One of the things I didn't address in the report, and I draw it to your attention now because perhaps I should have done, was that there is no requirement for training in taking samples, or indeed working with women to have a successful cervical screening experience, i.e. getting a good sample and getting the consent of the woman. There is training carried out, and some very good training carried out, but it's entirely voluntary. And I really wonder whether that it shouldn't be compulsory, that there should be a modicum of training provided for all of the clinicians involved in taking the samples, dealing with them. If only to make sure that they can explain properly to the women what is happening, and also in the context of the whole programme shifting really quite significantly next year to the HPV testing as a primary test, which will be much more accurate. So,
just to clarify, you were saying there was no training provided?
No, there is training provided, but it's entirely voluntary. So there's no requirement for people to be properly trained.
So someone could be providing the service without?
Yes.
And would that be unusual?
It would be far from ideal, said that way. And for example, I'll give you a really good classic example, which I came across several times, was that women who had a normal smear result, and then in the relatively short period after that developed symptoms that would otherwise have been regarded as really quite serious symptoms and indicative maybe that there was something serious going on. When they came forward with those symptoms, they were told, "Oh, you've just had a normal smear. You've no need to worry. Come back, go away and come back if it doesn't stop." And there seems to me to be a failure of education there, in that the staff didn't understand that the test might not pick up everything, and that serious symptoms should be dealt with on a serious basis, irrespective of when they occur. And there was some evidence of delays in treatment of women happening because of them having a normal smear that was regarded as that it couldn't possibly be a serious cervical cancer issue. So I think education of staff is extremely important, and education of patients and cancer in general about early recognition of symptoms, and giving patients the knowledge to come forward, recognise their symptoms, come forward with their symptoms, and to be able to engage in discussion with doctors and others about how these symptoms need to be investigated. I think public education is important as well as professional education.
Sorry, could I just ask one other question in relation to the over 200 people where it has been identified that the smear results were false? At the time the audit was carried out, were all of those in receiving cancer treatment at that stage?
Some of them may have finished their cancer treatment because it might have been at an early stage, but they had all been diagnosed
prior to the audit.
Prior to the audit. A diagnosis of cancer was the starting point of the review. Yeah.
Okay, so every one of them had already been diagnosed prior to the audit being carried out.
And that, in fact, was one of the misunderstandings that was quite common in the press, I think, over the last 6 months. Some people thought, mistakenly, that a diagnosis of cancer was being kept from some of these women, and that was never true. The review of the slides only took place in cases where there was already a diagnosis of cancer.
And when the audit was carried out, was there any additional people identified as having cancer that hadn't been previously identified?
No, as I said, it was only carried out on women who had been diagnosed with cancer. But as I pointed out and answered one of the earlier questions, it was only the women who had been diagnosed with cancer that CervicalCheck knew about, because they had no arrangement for exchange of information with the cancer registry in order to get the full notification of all the women.
Very quick clarification of that.
Yeah.
As we sit here on the 10th of November,
October.
Sorry. This election stuff is going to my head.
Are you calling it?
Yeah. But as we sit here, have the HSE given permission to the National Cancer Registry to transfer all of that information?
Yes. I think the Minister has.
Are you certain it has happened?
I am. Yes, the Minister was requested, I think, by HSE to give permission, and the Minister did, and I understand that there was a data transfer. I'm not sure whether ministerial permission was actually required, because I couldn't see the obstacle.
I asked this question months ago, and I never thought it was required, but they hid behind it the fact that they thought it was required.
Yeah, I find that unsatisfactory. They managed it with regard to breast cancer, and if they thought there was a problem, all they had to do was ask for a transfer to take place. All they had to do, and as you'll have seen from the report, I was very concerned that there were no, apart from a 1-year contract document that we're not even sure was signed by those sides between HSE, CervicalCheck and the Cancer Registry, there were no written agreements in place to cover this transfer of information, which was really unsatisfactory and bad practice.
You might just check. I'd encourage you to check, because I'm not sure it has transferred.
Thank you, Deputy Kelly. Now, Deputy O'Mahony, please.
Chair. First of all, I'd like to welcome Dr. Scally, Dr. Denton and Ms McEntee in, and thank you for coming in, and indeed thank you for a very, very good report, so well done to you all. So a lot of my specific questions have been asked already, but I suppose I'm quite concerned that the confidence has been lost in the whole system. So I was just wondering, besides the implementation of your recommendations, what else do you think can be done? Like what I'd hate to creep in is women saying, sure, why bother getting tested? You know, so just going forward, what do you think, besides the implementation of your recommendations, could be done? And do you still maintain there shouldn't be a commission of inquiry? And if you were back again, would you change any recommendations, add any, take any away, or whatever? Thank you, Chair.
Thank you very much, Deputy O'Mahony. Dr. Scally.
Thanks. Let me deal with those questions. Your final question, it wasn't me maintaining. This was my view expressed in the foreword, that I didn't think it was necessary. I still don't think it's necessary. But there will be another opportunity for me to reflect on that when we finish this next piece of work, and how satisfactorily we will finish that. Then I'll have a look at it. Were there things I would include in terms of recommendations that I haven't? I think I mentioned one. I think I probably should have said something about this issue of training. And it's particularly crucial, actually, because of the shift to the primary HPV screening within the next 12 months, hopefully. Because that's a big shift, and it's a whole new set of learning about the system for all of the people who are involved in women having the test, and also the health professionals that they're interacting with in doing the test. So I think I would, if I had a 51st recommendation, if you'll allow me a 51st recommendation, it would be that there should be compulsory training for everyone. And your other, was it?
The loss of confidence.
Oh, improving confidence, extremely important. I think one of the most distressing things that I found was the degree to which many of the women with whom I interacted had lost confidence in their treating clinicians.
Yes.
And I was really, really, really disturbed by that. And it was brought home to me actually in the first of the meetings I had with the women and in Dublin early in the process. And two young women came to that meeting and sat down beside each other purely by accident, and then found they knew each other, and they'd been at school together, and they were both in the same boat, and they were both from the same place, and they both had cancer, and they both hadn't been, in their view, disclosed to properly when they should have been, and they both lost confidence in their clinician that was looking after them. And as they were discussing it, they discovered that they both decided to shift to the other's clinician, and they thought this was very funny. And it was the only light-hearted moment, I think, in the meeting. But I think that brought home to me how difficult this is for many women, and we're still not through that at all. You'll understand. I said at the outset, and I hold it still to be true, in fact I hold it more strongly to be true, that when things go wrong, there are three things that patients want to happen. They want to be told what went wrong and why. They want someone to say sorry for something going wrong, and they want it to be someone who means it. You know, I don't think getting a letter from the chief executive or something or other, you know, the same letter sent to everyone, really cuts the ice here. When things went wrong and they weren't disclosed to, and the people who didn't do the disclosing, that probably should have done the disclosing, should be the people who are saying sorry, and, yes. And sitting across the table mistake, yeah. With women. And the third thing is they want to be sure it won't happen to anyone else. And if you can do those three things, now we've gone a long way to find out what went wrong in the system and why. We haven't got to the stage, I think, where you know, and I had a meeting with, as you'll know, it was in the press yesterday. I had a meeting last night, a very long meeting with the women. And it's very clear that they're still very angry about the way they were treated, and that's not going to go away without some active intervention, if it ever will. If it ever will, I really hope it.
I hope so.
I hope it is. And then there is the more general issue of loss of confidence in the programme. Happily, screening numbers haven't dropped off, but you know, it's still only about 80%, so there's a real, and we shouldn't be satisfied with it only being at 80%, because that's 20% of women, you know, who are at risk here, and the system needs to get better at convincing women that this is a good service and a service that they should come to, and they'll be welcome to, and they'll be looked after properly. So I think there's a great opportunity now, a new, much more accurate test coming in. And I think a large amount of work on that, and a large amount of work as well on HPV vaccination, which is, those two things together are the way forward. But it'll not happen without people putting the effort in to regain the sort of confidence you're talking about, the public confidence as well as the confidence of the women affected.
Thank you, Doctor.
Deputy O'Connell, in other screening programmes elsewhere, is the uptake better than 80%?
The answer to that is mostly not, actually, and many countries are struggling with fall in uptake for reasons that are not fully understood. I think I would just add in, although the numbers of women having samples are very high at the moment, many of those are women who are taking up the offer of additional tests, and we don't necessarily know that they are the ones whose test was actually due. I think raising uptake is something that this programme in particular should be focusing on, because it is still quite young. And if you compare it, for example, to the English screening programme, that has been running for very much longer, so it's a whole different calculation around uptake. So in a programme that's only been running for 10 years, achieving the high uptake is particularly important.
Thank you very much. So now, Deputy Kate O'Connell.
Thank you. Thank you for coming in this morning. And thank you for the work you did on this report. And I was conscious over the summer that people were saying that it was a very good report, and it is a very well-written report. And I think any of us that were involved in the discussions here, both the Health Committee and the Public Accounts Committee, I suppose wonder how you got so much information out of them when we failed here to extract the information. However, the report is very damning reading, so the content is not good, although it's put together. So the first part of your report focuses on the move from HPV, or from screening to HPV, and the benefits of that, and that's great. We're all for that. And what I want to focus on today is the problems that I've come across with, that I'm concerned about reading the report, and perhaps you might be able to shine a bit of light on them, and some of the things that have come up today. So the QA, am I correct in saying that the quality team in the HSE weren't the people that went over to audit the labs, and they didn't know that this other secret team were going over, and that there was a meeting when they came back from America where everyone said you did a great job, and then they moved on? Is that what happened, or did I misinterpret the report? So it's in so on page 30 of the report.
Oh yes, I think I understand what you mean.
Yes.
I get you.
Am I right in saying that the people who actually were the QA were not the people that went over?
No, it was a QA team, but it wasn't the QA committee.
Yes.
All right, so it was a team within.
Yeah. As I was explaining earlier, the Quality Assurance Committee had an external chair and met on a regular basis during the duration, and the quality assurance visits were carried out by a mixture of CervicalCheck staff with an external cytopathologist with them on the visits. And they came back, and there was some discussion noted in the minutes of the QA committee, but what really is missing is process about following up on the QA visits and carrying through on the recommendations.
And when this QA group went to the States and they went to the labs, they came home blissfully unaware that the labs they had just audited were sending slides to other labs.
In one case.
In one case, so far, you know.
With the accreditation, the iOS accreditation, that to my mind, it states in the contract that the labs had to be iOS accredited, and it appears I can't just find the page in the report, but there's a page where it says the difference between iOS and CAP, and to me, there's a distinct difference between the standard. So our contract had for iOS accredited labs. However, what we got were CAP, College of American Pathology, I think, accreditation, which is kind of like maybe the yellow pack version, or maybe you don't get the yellow pack, but what's the equivalent in the UK? Safeway, I don't know. But you know, it sounds like, to me, like a distinctly lesser standard of accreditation, and they say it's equivalent. Thank you. It's on page 61. Yeah, so they say it's equivalent, but really, from my reading, and I have a background in science, it is not equivalent. They may have been getting similar results, but CAP and iOS are not the same thing. Am I right in saying that?
You are absolutely right, and you read the intention of the table very well. I think the intention of the table is to make it clear that there are significant differences between the two. That is one of the issues we'll be looking at in the contracting and tendering, because although we have been told that, and the labs tell us that at some point it was recognised by CervicalCheck that their accreditation, the CAP, was accepted. We haven't seen any documentary evidence of that, and we're still going hunting for that. And in addition, That table you referred to on page 60 lays out some of the differences. But we hope to do a much more detailed analysis of the two systems and find out what the differences are. One of the interesting things is that the CAP, the College of American Pathologists, their training arm also does ISO accreditation, and some of the laboratories are now obtaining ISO accreditation.
But the simple fact of the matter is that which was in the contract was not the standard at the other side.
That is right.
Not only that, no one told us. No one wrote an email and said, by the way, you want iOS, but we have CAP. Will that do you?
Well, I'm not sure.
Or is there any evidence of that?
Well, we do know that despite them not having ISO accreditation, they were given the contracts, even though it was plainly stated in the call for tenders that ISO was a requirement. So we know that. There is disputation about the degree to which CervicalCheck agreed that it was equivalent, and that's one of the issues we're digging into to try and answer that. And as well as that, we're going to look at how equivalent the two things are. We'll do a much more detailed comparison of the two, all of which speaks to the point that Dr. Denton and other colleagues visited all of the current providers as well as CAP and conducted their own detailed look at the quality of the services at the present time. And it's on that basis that we were able to say that we could not see any reason why the current contracts could not be rolled forward. Not on the basis of their accreditation standard, though they do meet all the standards that are required in the US.
Sure, we're not in the US.
We are not, indeed.
So just then to move on to something else you spoke about earlier, I'm not sure in response to whose questions. I asked it at some committee on this issue in the last few months about the baseline which we were operating off. And today somebody spoke about the colposcopy being blended in with the regular smears. Now, to me, that's baseline distortion. You're going to get just bad data out of that. And to me, this morning, that's the big light that's shining on this, is that distortion of the baseline and how that happened. And I did ask that question in here of the HSE, and I think I was pretty much dismissed that it could be, you know, an issue. This is at the back when we were trying to get to where you got to. So if you distort the baseline, and if your limitations of your testing is, we'll say, a 30% failure rate. I mean, the concern, I suppose, what we're hearing at the minute is that the audit process has been stopped, and you have somebody like, you know, who's had 2 false negatives, like we've had the tragic case of the lady being buried today, and the other cases. So I don't think we can have confidence in that, I suppose, this 30%, if the figures have been distorted with colposcopy slides. I don't think we can actually say that those labs are falling within 30%. Am I wrong in saying that? Limitation rate. Because if a cohort of the 100 definitely have cancer, well, they're going to mess up the figures.
Yeah, so I think there's 2 separate things. So the figures that we've got and that we can look at are not telling us about women whose cancer has been missed. They're telling us about the proportion of women who have abnormalities detected, the vast majority of which will not be cancer. There'll be changes which, if left untreated, might at some point over many years develop into cancer. So it's not an absolute measure of the laboratory's ability to prevent cancer from occurring, but it's a reasonable surrogate because it's data that is relatively easy to get, or it should be, and it's current. Because, of course, a lot of the problem is when you do a look back, many of the samples that have been looked back and re-diagnosed or diagnoses altered were taken many years ago. And I think, although it tells you something useful, it doesn't necessarily tell you how that laboratory is functioning today. So I think it's really important to keep the two things separate. There is no measure of how likely a laboratory is to miss a diagnosis that will lead to cancer in a sample reported today. We simply can't measure it. So as a surrogate, we look at how good they are at detecting precursor abnormalities today, which we can do. And that's, and in terms of sort of real-time monitoring, that's the best that we can do. And then the audit tells us something different, which is what it should be doing from the point of view of improving laboratory practice is identifying samples where a diagnosis was missed, perhaps very difficult, as Gabriel was saying earlier, but then using that to feed into training, to feed into supervision. But to be honest, I would think it would be very, very unusual for a poorly performing individual member of staff to be detected through the audit, because it's too late. You know, they've already been reporting for another 5 years at that point. So a lot of the quality assurance measures that we look at are process measures. How do they check up on members of staff? How do they monitor their performance? How do they detect problems in real time? Because that's what you really need to do to improve.
I mean, one of the major concerns, I suppose, is that when the audit of many of the cases, the 221 cases, the language of gross misreading and, you know, very obvious cancer cells on the slides. So this process is going on 10 years, and this 25 to 30% limitation that we have, has that not improved over 10 years? Have things not been done to maybe make that 20% or 19%? It just seems strange that anything that has a limitation hasn't improved over the years. Is it the case nothing has changed? And when it was being designed as a screening cervical, have we any data that we can look at when we decided that at a 25 to 30% failure rate or limitation, when we were devising it, were there slides with obvious cancer in the trial or the setting up phase? There's a major concern that the slides that have been reviewed, I haven't seen them and I'm not qualified to look at them, but that they are riddled and very obvious. Now, maybe that's just media reporting, but it's just a concern of mine. And how, when the genesis of CervicalCheck, was it normal that in that 30% there were people like the people we have? If I'm making myself clear. Thank you.
So, I mean, we haven't seen any sort of published outcome of the pilot that was done over a number of years prior to implementation of the CervicalCheck programme. I don't believe that it included any look back of women who developed cervical cancer. There is some comparative information from England where a similar audit has been done, and we included the outcomes from that, which have been published in the report. And that shows a degree of lack of concurrence, which superficially, at any rate, looks broadly in line with what's been reported, or what we think the CervicalCheck audit shows, although we haven't got a sort of an equivalent report to compare it to. In terms of have things changed, yes, I'm sure that things have changed, and we did see evidence of things changing. If you look at the reporting rates for abnormalities over the years, you can see step changes which must indicate that there was some change in policy which occurred in a very short period of time, for example with inadequate reporting. So there is evidence of constant intervention and evolution and improvement, as you would expect, but it's not. We don't have specific information about look-back findings in individual women's samples. The RCOG review, again, may be helpful in that respect.
Thank you, Dr. Denton. Now, the next contributor is Deputy Bernard Durkan.
Mr. Chairman, I thank Dr. Scally and his team, Dr. Denton, for the work they've done and the time in which you've done it. And in actual fact, there was no need to apologise for any perceived delays at all. In fact, it is far better to do the job thoroughly, given the importance of the task. I think it would be complimented entirely on the way you set about doing that, because one can involve oneself in a long tirade about who, why, where, what, and end up still in the same position as starters. Can I ask a couple of questions in relation to, for instance, the issue of full disclosure, open disclosure? Do you think, from your own observations, that there was a resistance to full and open disclosure and a culture of resistance to full and open disclosure, which may have had a bearing on the degree to which the various professionals responded to their patients? And that's one question. The other one is, every system, in order for it to operate, there has to be confidence in the system. This has been referred to already, Mr. Chairman. And I would fully appreciate that the confidence system has been dented, and I understand that. And a question that actually occurs to me is the two ladies referred to by Dr. Scally who had switched consultants. What was their experience afterwards? Did they have a similar experience afterwards, or was there a change in their experience having switched? And the other one is the accuracy of the tests of the screening programme. Do you think that 80% accuracy or 85% accuracy, whatever the case, do you think, in your opinion, again, that had a bearing on the seriousness with which those examining the slides might have taken it? For instance, well, you know, this is only an 80% accuracy, or whatever the case may be. Surely, you know, we can't be entirely accurate about this. Can we just move on? Also, that's the next question. The next question is in relation to how the screens, the slides are examined. In your opinion, is it better to have two different people examine the slides at different intervals or at the same interval, rather than have the same person review their own slide, as it were? Which, in your opinion, is the better of the two options? My own preference would be, I would have thought that a different examination, a different person, provided that they had no prior information as to what had happened before, because then they would obviously be unbiased in the way they go about it. How many other countries or jurisdictions, to your knowledge, have had a similar process to the one applied here, the screening programme? And how did it work? Did it work better? Did it work more accurately? What are the stats, the comparative stats, if you have them? And you mentioned at the very beginning, in inoculation programmes in different countries, there may be reactions in some cases. Is it possible to identify patients who may react with any degree of accuracy to a particular inoculation programme? It would be hugely beneficial, again, I know, to all the practitioners, if it were possible to find that. The last question is in relation to the implementation of your recommendations. Are you satisfied that they will be implemented unconditionally? Because again, there's no sense in going through all the trouble and work that you went to examine the issues if the recommendations are not taken into account, put into operation instantly. Thank you, Mr. Chairman.
Thank you very much, Deputy Durkan. Dr. Scally.
Thank you very much. Interesting set of questions there. Well, open disclosure and how it operates. The acid test is how it operates in hard cases, and these were hard cases, and it operated badly. And I would like to be able to say that there's really good experience elsewhere, but there hasn't been good experience elsewhere. The hyponatremia inquiry, in which I had some involvement in the north of Ireland, actually uncovered a much worse situation of cover-up and lies and dishonesty amongst clinicians. And I'm deeply disappointed that medical colleagues would behave in that sort of way. But when it comes to hard cases, there is an element of collegiality in the medical profession that is at times good and is at times unhelpful. And it can be really unhelpful when it comes to telling patients the truth and telling authorities the truth about things that are going wrong. And I'm very hopeful that will be changed and can be changed. Switching clinicians, I don't know if they went ahead with switching clinicians. They did. I was hoping to ask them last night, but they didn't come last night. And I would like to know. I don't know if they will have. I suspect they should have gone ahead and switched clinicians, because sometimes it's easier just to start afresh with a different clinician and build a new relationship, especially if there's any resistance to going back and sitting down and speaking the truth to each other. And that's a difficult thing for them to do. So I look forward to hearing about that. But I do worry, and women continue to tell me that they're worried about the relationship with their clinician because of all this, and they would love resolution to it, and I would hope that they find that, and I would certainly encourage any attempts that might be made. And I know some of the women would like to sit down with their clinician and they would like to discuss what happened in the light of my report and in the light of everything that's happened. They would very much like to say how they felt about what happened, and they would like the clinician to tell them really honestly what went on and so on. So I know some women would like that. Interesting, your question about the inaccuracy of the test being used as an excuse for complacency, actually, I think is what you were hinting at, which is an interesting thought, and I will think on that further. I certainly, in some of the reactions of clinicians in dealing with women, they've dismissed things that went wrong on the basis of, we all knew the test wasn't completely accurate, and that's not. I agree with the sentiment, I think, that lies behind your question. I think that is not right and not helpful, and it's our duty to make the test as accurate as we possibly can. And I'm very hopeful that the shift to HPV next year, which is a much more accurate test, will reduce that problem. Inoculation, we're not really here to discuss immunisation, but part of the issue with the immunisation is that there are people who should not be immunised because of the likelihood of them reacting to a vaccine, and they are entirely dependent then on the rest of the population who can have the vaccine, having the vaccine. I wish there were a way to identify all people who react. That, sadly, is not possible. And it comes back to what we were saying, I was saying very early at the beginning about a compensation scheme that runs in the UK for immunisation. It is a limited amount of money, and there's a high level of disability involved in the judgments about that, but nonetheless, it's an important thing to look at. Dr. Ted, would you like?
Yes, so I think there are a couple of other questions that you asked that were laboratory specific there. So when you asked whether the perceived accuracy of the test impacted those doing the audit, I heard two aspects of that, one of which is the clinicians, but then the second one is actually in the laboratories. And I have to say, from the people that I spoke to in all the laboratories, actually, they were all very committed and keen to actually re-looking at these slides and learning what they could from them. But it does then interact with the question of of bias, because they knew that these women had all developed cervical cancer, and I think different individuals had different approaches to how much they tried to compensate for that bias. And I don't think that that's actually their fault, because nobody told them what they wanted them to do. There wasn't a protocol that said you either must or you must try not to compensate for this review bias. But I think I do want to state that the clinicians were all very keen to learn what they could from reviewing these slides. The protocol, such as it was, did list cases that had to go for an external review, and that's on page 86 of the report, 86 going on to 87. So basically slides that were identified on internal review as having a significant difference were sent for an external review, which I think addresses the question that you're asking about, has there been another pair of eyes on them? And of course it's then the difference between those internal reviews and the subsequent external reviews which precipitated CervicalCheck into wondering if there might be an issue with the internal reviews. You also asked about how many other countries do an audit like this, and the answer is not very many. It's really quite unusual, and the one that we're most familiar with is the one that runs in England and Wales, and I think, but I think it should be recognised that trying to do the audit is a very laudable thing, but that not every country, and in fact most countries, have not had this experience. So there is not an awful lot of comparison to go on.
Is the audit beneficial in general to the quality of the service?
Well, my view would be very much that it is, yes, because it, and we do also have to note that it's the whole patient pathway. It's right through from sample taking to cytology, to colposcopy, to management afterwards, and also histology and anything else that happens to that patient during the pathway. Most of the cases that have been identified as problems have at least some cytology component here, but there are issues that have been picked up in other parts of the pathway as well. So it is producing good outcomes that should give grounds to implement changes, and I think what we would really like to see is a better process for identifying them, and then perhaps through a national screening committee saying the audit has shown us this, what can we do about that, and then implementing changes on an evidence-based basis.
Deputy Director, there was one further point. You asked about implementation, a subject I'm very keen on. I've seen too many reports with lists of recommendations that are still lying, gathering dust. And I was part of the Madden Commission some time ago now, which looked at issues around clinical governance, and plenty of those recommendations, good recommendations that they were, are still awaiting attention. I was cognizant of trying to keep the recommendations to a reasonable number. I did my best to keep it to a reasonable number. And I'm also very keen on the implementation. And I said in my foreword to the report that needed external scrutiny, the implementation. And the Minister has asked me to carry out that scrutiny at 3 months to see how the construction of the implementation plans are going on. And I've made a promise to the women and the relatives that I'm not going to disappear on this, and I take these issues extraordinarily seriously. And I haven't spent the last 4 or 5 months working, and my team working extraordinarily hard to deliver you this report, and your appreciative remarks are very much appreciated by me and by the team. We haven't worked this hard just to walk away from it and let it sit there, and we will be as engaged in the process as we can be, within the limits of what I'm asked to do by the Minister, to ensure that implementation takes place. You can be assured of that.
Thank you very much, Dr. Scally. And just before I bring in Senator Dolan, could I ask, in relation to the patients who went through cervical screening who were identified to have cancer, looked at all of those cases?
Only the cases that CervicalCheck knew about.
Right.
The National Cancer Registry knew of a wider range of cases, a wider group of cases.
But of the group that CervicalCheck knew of,
Yeah.
the 221 cases,
Yes.
are they cases where there was a misreading of the smear on their previous smear R2? So there were many cases which CervicalCheck knew about,
yes.
which had a clear previous smear, a true false negative.
Let's try and get to this. It's a really important question, and between the two of us, we will try and give you a precise answer on that. Firstly, there were a set of criteria used to look at all of the cases that CervicalCheck knew about, and we have slight doubts about at least one of the criteria that they used, which is there's an 18-month cut-off point in there, which Dr. Denton will address in a second and explain exactly what our problem is about that. And then they made a decision as to where the areas of the screening process that needed to be looked at lay. So it could have been in colposcopy, it could have been in the management, the call-recall system might have failed, or it could have been cytology. So they decided to look at that broad sweep of areas. The 221 are areas where, after the slides where notification was sent to the laboratory that this was a case and that they should do a review, and a notification come back from that laboratory to say that what the result of that review was. And that was then judged within CervicalCheck, and they identified the cases for disclosure on the basis of that there had been a change or an alternative reading of the slide, which, if it had been the original reading, would have resulted in a changed pattern of management. I think I've got that correct. And Dr. Denton will just deal with this important
pattern of management.
Yes.
Break that down.
Oh, well, that there would have been a different intervention at an earlier stage.
That's for the public clear. For the public, that's clear what you just said.
Yeah, sorry, Deputy Chair, it could be either one of those two, that there would have been a different intervention, maybe an intervention took place, but
I understand.
It should have been a different intervention, or that there should have been an intervention at an earlier stage.
That's the critical point.
Yes, it is. That is.
But that intervention may have been an earlier recall, as opposed to...
It could have been any of a range of interventions. But we need to deal with this other issue of the 18 months, because we expressed our concerns about this in the report. But it's worth explaining, I think. Dr. Denton.
Yes. So. The CervicalCheck appeared to have made a decision in trying to identify which women's management would have been different if their cytology report had been different, that they would place a cut-off at 18 months prior to the diagnosis of cancer for that. So they were basically saying that if a woman's missed abnormality occurred 12 months before she was diagnosed with cancer, it wouldn't have made any difference to the final outcome, whereas if it occurred 20 months before, then it would. And we feel disquiet about that, because cancer can progress quite a lot over a period of 18 months, and that might make a difference. It might make a significant difference to outcome, in our view. And there was certainly one point where that was discussed in a meeting, and that was agreed as a criteria. However, what I'm still not clear about, and in fact had some more information from HSE on Monday of this week about this, is how that relates to the 221 women. So I'm not yet assured of the exact criteria for identifying those 221 women. They were certainly women who had a diagnosis altered on review, but whether there are more who had a diagnosis altered on review but it wasn't held to have made any clinical difference, I cannot at this time tell you.
So just to clarify that then, if there was a review of the reading of the slide,
Yeah.
and that slide was done within 12 months of the diagnosis of cancer, it didn't become part of the 221.
I don't know the answer to that. I'm concerned that it might not have done, but I have not yet got the answer.
If it was done more than 18 months previously, it was included in the 221.
Yes.
And
Sorry, this is extraordinary.
no, this is in the report.
I know that, but it's extraordinary the way it's been outlined here now.
Yeah. And we're outlining it for you because of our concern about it, to draw attention to our concern about it. That,
The dialing up of it is what's extraordinary. Is what it is.
Is that assumption of the
This 18
difference
months.
between the 12 and 18 months, is that was decided by CervicalCheck at that meeting? Is that based on any international data, that decision, the 12-18 month cut-off time? I don't think...
we're not aware of any basis.
I don't know any international data.
We're not aware of any basis for it, which is why we drew attention to it.
And have you asked the question as regards who came up with it, why they came up with it, how they came up with it?
Yeah.
Because I don't remember that in the report.
We're still seeking, as Dr. Denton was saying, we're seeking explanations for it. But it's part of... When you look at the protocols for the review and the audit, they are scanty in the extreme.
So if I can just, the key part is on page 90, and I think the problem is, and the reason why I'm being slightly, it might come across that I'm sounding slightly indecisive about this, but the problem is that we haven't got exact definition of which patient groups are involved. So if you look at the first few paragraphs of section 8.4, we did find a partial presentation of the audit in 2015, and it talks about a review outcome for 190 cases that were known then, and in 100 and it runs through the number of women and how they decided whether or not those had impacted on management. But what we don't know is whether is how a proportion of those 190 women relates to the 221 women that we have now. So I cannot, and I've been very concerned about this, and that's why I've been trying to get some more information this week, which is still incomplete. But I'm still not assured. It may be that there is no delay factored into the 221 women, but it may be that there is, and I think that we have to be aware of that, and that in fact that there may be other women whose samples were altered on review who haven't been included within that 221 group, plus the ones who are in the cancer registry group who we know haven't been included. So
just to clarify, because this is slightly complex, sorry Chair now, but essentially what we're saying here is the 221 obviously we know about. We know about that there's others from the cancer registry, and you're going to clarify what I asked you earlier on relating to the passing over of information, which we still haven't 100% certainty of, but you think is there. But also because of the parameters that we now know were set, which to date we don't know the full reasoning why, that with the timelines of the 12 to 18 months, that there could have been other women where there was, just to conclude, where there were alterations, but they wouldn't have been included in this. Is that what we're saying here?
That sums up our concern. Yeah, as we said, the decision to view 18 months as a cut-off for clinical impact is undoubtedly flawed, and it's hard to see the logic for this. That's what we said in the report.
And on page 90, the UK audit went up to 2 years. Is that right? Am I reading that right? Sixth line from the bottom, or am I comparing apples and oranges?
So, no, for the UK audit, it assumes that samples taken within 6 months of the diagnosis of cancer were a diagnostic sample. Because obviously you don't want to include a review of the sample that actually precipitated the diagnosis. So you have to have, because that's the one that worked, so you actually have to have a cut-off. So in the UK it's taken as 6 months. 18 months is very long. But I must reiterate...
And to support that 6 months in the UK, what evidence was used?
It was process evidence that we knew that samples taken within 6 months were usually the one that actually led to the diagnosis of cancer. So I think, I do just want to stress that we know that in 2015 they set what we considered to be a non-evidence-based time limit. What we don't know is whether that was reversed. And in fact, we still don't know the exact definition of who they wrote to in the 221 women. That's fair, isn't it?
You've asked the HSE these questions?
I've started to ask them because I didn't realise it was a problem until very recently. So I've had a response from them this week through the RCOG that says the 221 women were women whose diagnosis was altered on review. It doesn't say anything about timescales, so I need to pursue that further.
At this committee, we continue, and at Public Accounts, we continually heard that the trigger for the audit was to have cancer, and at no point did anyone ever mention a 12 to 18 month.
No,
in all of our discussions, it was never ever mentioned.
So it is still the trigger for the audit is still having cancer.
Oh, I know that.
And women who had smear more or less than 12 to 18 months, they were all reviewed. What we're uncertain about is which ones generated a letter.
But they'll all be included in the RCOG review.
Providing
that will encompass all of them, and it'll encompass the cases that are identified via the cancer registry as well.
So it doesn't answer what happened here, though?
No, it doesn't answer, no.
So is the case then that there could be more than 221, given the
Oh, I think that's
less than
undoubtedly.
18 months?
I think that's undoubtedly. That will be, I think, the outcome of the RCOG review, undoubtedly.
Sorry, Senator Dolan. I interrupted your entry.
You're elevated.
Elevated to the lower house, but your repeated mistake of calling me Deputy Dolan and then your fulsome apology is very appropriate today. And it comes from a doctor, full disclosure and fulsome apology straight up. The problem is, though, and you put your finger on it, it's when it comes to the hard cases, it sticks in our craw to come out and say it. Thanks for that introduction. That gets me going. I want to just, of course, thank you and your colleagues for the work that you're doing, and I want to situate my remarks and my questions related to the situation, the comfort and the status of girls and women in Ireland, because there's something going on here that isn't just about the eye of this storm. It actually goes to the heart of how comfortable and included and treated well are women and young girls in this country. That's just an observation. At the start of your remarks, Dr. Scally, you said to ensure an increasingly rare event. And you went on to honour, and I want to just come back because I think that's very important, honoured to meet and talk to many of these women. And that you said, I took great encouragement from their help and support. I think those remarks need to be underlined and repeated. I have 3 or 4 questions. What, in your view, or do you have a view, that there are governance or maybe governance and organisational issues that stretch from the Oireachtas itself. And we're a committee dealing with health, just the two houses of the Oireachtas, through the relationship with the Department of Health and into the HSE. And I'm saying that because it's easy for us here to talk about what happened there, but nothing just happens there that doesn't have responsibility and oversight levels. The other, moving on to my next question, I don't think that anyone would regard the cervical check screening or other health screenings as other than positive and very positive developments. And I suspect and I guess that as time goes on, there will be more of these proactive interventions to try and catch nasties before they come our way. So it's just so intriguing for me that how does having a good health motivation turn out to cause unnecessary deaths, near deaths, and cause huge anxiety to people. So any observations that you have on that, I would appreciate. You talked about, in relation to clinicians, a lot of these attitudes have no place in medicine. And that was about the issue of open disclosure. And then you went on and talked about attitude and culture. I think you said you were hopeful that that culture will change. Now, you did say open disclosure has to be the rule rather than part of the menu. What other things might, or do you think, are necessary to, let me say, encourage that change of culture? You did talk about the collegiality being a good and a bad thing, and I think we see that across other areas of public service as well, with policing and various other areas. Then to come to, early on in your opening remarks, you were strong on compensation being a core element, if I heard you properly. And my straight-up question is, should a compensation fund be costed into, in other words, become a part of the cost of providing the service? That, now, you'll always hope that you don't expend it fully, but that it strikes me that if you're going to have open disclosure and honesty, that we all have to be honest with people and say, you know what, sometimes with all the best will and whatever, there'll be honest mistakes, and we have to have up front a system that tries to remediate remediate that. Finally, again in your opening remarks, such were the range of deficiencies I found, and you got to 50 recommendations and maybe a 51st one this morning to get over the 50 mark. In terms of the public, we're sort of used, we've 20, 25 or more years of tribunals, inquiries, scandals. It strikes me that this just can become, sadly, another one with a big report, and it's all laid out there. And could you, if you met someone at a bus stop or you're in a waiting room with somebody and they realised who you were and they said to you, look, in a word, what are the 3, 4, 5 things that need to happen to actually turn this around? And my final, it's an observation if you want to comment on it. We have had a love affair with finding people and entities to blame, and responsibility does have to be placed. But when something like this happens, we need to immediately turn into how do we actually start to right the ship straight away in whatever way we can, and then get a better system in place. Thank you.
Thank you. That's a fine set of questions, if I may say so, Senator. The Oireachtas and potential role in it. And if I can link that with almost the last bit you talked about, finding people to blame. It was undoubtedly true that there is an appetite for finding people to blame, no doubt about it. But in this situation, I don't know where you stop. Your invitation to speak about the role of the Oireachtas and the role of politicians in all this, one of the reasons we're in the problem we're in, as Dr. Denton has indicated, cervical screening is relatively recent in this country, and only in the last 10 years. It has been in place in the UK for 20 years. It's been in place in quite a few other European countries for much longer. I personally find it difficult to understand why it took an 8-year pilot before the programme was introduced. An 8-year pilot? That doesn't make sense to me of a programme that's well tried and well tested elsewhere. I have no idea. As you will have gathered in the report, I'm critical about the removal of the external governance of the HSE and that situation going on for so long. I'm very pleased that it's being restored, and I'm very pleased indeed with the appointment of the chair. I think a fine chair has been chosen. I have confidence in that person. I am, I think it's very unfortunate that things happened like the decision to postpone the implementation of HPV vaccination at a time. I'm very pleased it's in place now and is on the way up in terms of the rates now. But there was a decision made to postpone its implementation. As I've expressed already, I'm a strong advocate, and I hope there's no argument about it anymore, about the necessity of a statutory duty of candour placed on individuals, and the Oireachtas had the opportunity of doing that and chose not to for whatever reasons. So, I think you can look at through the entire system, right from legislators all the way down to the people on the ground, and find things that didn't go well. And you ask, I said I'm hopeful that culture would change, and I'm by nature I'm not an optimist, but I also come from Belfast, and in Belfast there's a saying that an optimist is someone who hasn't heard the bad news yet, and I hope there won't be bad news about these 50 recommendations, and I hope they will be implemented, and I hope the country will get the cervical screening service it deserves, and I'll certainly be doing what I can and what I'm asked to do to help that. Changing the culture. Through the report, I've indicated that there are certain things that need to be put in place. The National Screening Committee Centre, and your question about other programmes and the future of other programmes, particularly with the modern age of genetics. I feel quite confident that there will be other screening programmes coming forward. Yet, Ireland does not yet have a mechanism, a proper mechanism for looking at screening in a highly professional, consistent way, which is why I'm recommending a National Screening Committee be put in place. And I think that is something that will serve the country well in the future, and will enable a rational approach to screening and an oversight. But it won't have escaped your attention that in my recommendations I've recommended in relation to two things I've mentioned: the board of the HSE, that there should be patient advocates on the board, and I've recommended in respect to the National Screening Committee that there should be patient advocates on the National Screening Committee, and I've made other similar recommendations in the report. And I've been deeply impressed by the advocacy that's being shown by some of the people affected here, Vicky Phelan, notably, who exposed much of it. Deeply impressed. And as I was deeply impressed by some of the patient advocates involved in the Mountain Commission some time ago. And I would encourage that approach to involving patients at the highest, advocates at the highest level. But with one caveat on that. I remember the day when I looked around a committee that I was chairing, and we had included patient advocates, but as I looked around, it occurred to me that the only people who were not being paid to be there were the patient advocates. And I'm conscious that that is unfair and exploitative.
Has to be dealt with.
And that there are people in this issue who are making enormous sacrifices to try and aid and move it forward.
Here, here.
So I don't think in any sense we should be seen to be exploiting patient advocates. We need to find a way of helping them to actively participate. And there are good reasons why, because we want a mix of people from different backgrounds and different stages of their life involved, not just those who have retired and have the time to do these
Couldn't agree more.
things. So we need to sort that out, and that's part of changing the culture. I very firmly believe that. I think also a better understanding of citizenry amongst the citizens of the Republic of Ireland, and because I'm still not convinced that the public don't have too deferential an idea of doctors, and it's something that that they need to, I think, be more robust in dealing with the medical profession and have higher expectations of doctors. Really, the public shouldn't hold them in awe any longer. Those days have long gone, and I hope this report and the exposure of some of the ridiculous attitudes that they hold will encourage the public to be intolerant. Maybe also, because I come from Belfast, I'm an advocate of intolerance at times, and I think being intolerant of doctors that are patronising and sexist is a good thing to be, and so I would encourage people to address that. Compensation, I think your point is very well made, that part of the cost-benefit analysis of a screening programme should include issues of compensation for those who are actively damaged by the screening programme, just as it needs to take into account the sometimes physical damage that can be caused by over-investigation as a result of a screening test, or the anxiety that results from having a screening test and then having to wait a very long time for the results. That is a stress on people that should be avoided if at all possible. I firmly believe that patients turn to lawyers and litigation as a last resort in the absence of any other way of getting their issues dealt with. And the best way of stopping the lawyers getting involved and the costs getting involved is to go back to those three things that I mentioned about telling patients what's gone wrong and why, getting somebody who's responsible to say sorry and mean it, and then assuring them that everything will be done to try and that not to be repeated. All the evidence from across the world shows that if you do that properly, the public is much less likely to go to court to seek satisfaction. And I've seen it so many times, people going to court, suing, and of course the only real way that the courts have of responding to that is in terms of a financial settlement. And a financial settlement may be fine in one sense, but I don't think it brings resolution for a lot of people. So I think I look forward to Justice Meenan's suggestions and proposals and reading what he has to suggest in relation to that. I think the screening service, in terms of the, you asked for the 3, 4, or 5 things, key points. 1, open disclosure, absolutely. I think 2, a national screening committee. I think 3, screening services need to be brought out of the cold, given a higher profile within the HSE and better management. And the 4th thing I don't think we should do is, this is a negative thing rather than a positive thing, I don't think we should indulge in the blame game any more than we absolutely have to.
All right. Sorry, Deputy Kelly and Deputy O'Connell, I think, want to raise two short issues, and then I'm going to ask Senator Swanick.
I think in fairness to Deputy or Senator Swanick, he should go in ahead of us because it's his. Yes.
Brief. I just had a commencement debate in the channel there. I just had to pop out. Welcome, Dr. Scally and your colleagues. Just very briefly, I'd just like to welcome the call for the National Screening Committee. I think that's an excellent call to introduce new programmes and to modify the existing ones. Just very briefly, do you think is it acceptable that there's still no manager in charge of the cervical screening programme within the HSE? And with regards to the timelines for the HPV introduction, are you happy with those timelines? Also, do you believe that John Conaghan will hold relevant HSE managers accountable for their lack of performance as a consequence of this report? Who will be held to account for, we'll say, the contract mismanagement, the lack of quality assurance, the non-disclosure and the utter lack of communication? And also, finally, with regards to the labs, why were the labs not fully investigated when the HSE knew that there were issues? And I believe that this may still not have happened, even though the labs have admitted liability and many of them have settled in court. You may have touched on some of those already.
I think we did touch on those issues quite extensively already. Some of the others, of course, are subject to recommendations in this report, and the Minister has asked me to review progress on that, which I will be doing at the 3-month point. And I'll be able to answer, give you my view on those when I've seen the implementation plans that I believe are being prepared by the organisations. So if you'll forgive me, I'll leave that for a period of time. But the points are well made, and they're in line with the recommendations, and I expect to see them implemented. As for do I believe the HSE will do what they promised, which is to conduct their own internal investigation into the performance within the organisation? That's an assurance that was given by the acting director, John Conaghan, at an Oireachtas committee. I can't remember if it was the Health Committee or the PAC Committee, but he very clearly said that would happen. I would expect that HSE will do that. I certainly hope they do.
As I said, I agree with you, we're not into the blame game, but we do need accountability at the end of the day for the 221 ladies who sadly deceased.
I quite agree that we do. I mean, it's difficult to. I found it quite difficult to understand the level of poor management that went on. Going to meet some excellent staff for cervical screening in Limerick, as I did. And there were two things about it. One, I was horrified to hear the way in which they'd been subject to death threats and one person being spat on in public and so on, because some of those staff are absolutely excellent, dedicated people who deserve a great deal of thanks for their efforts over the year. They may not have been well led, but many of them are very good. The second thing was, because I knew there was a problem with people having proper job roles and job descriptions, at the meeting there I asked, with the staff who attended the meeting, I asked of the staff who attended the meeting, would you put up your hands if you have a job description? And one person put up their hand in that room full of people, and they all laughed, and I said, well, why are you laughing? And they said, oh, well, because so-and-so's only just joined the organisation, and that's why they got a job description. But none of them, not one of them. And it is really difficult, I think, to blame people for not carrying out the job when they've got no job description. They've no, it's very difficult.
The point actually is, if there's no description, well, then you can't be held accountable, because no one knows what your job is.
Deputy Kelly.
Thank you, Chair. I found today very useful, again, and I've gone through this report in great detail, but I particularly found the information regarding the 18 months, 12 months to be dialed up, and obviously in the last week it's become an issue for yourselves of higher importance, and certainly coming out today it's become an issue of huge importance for us here and for myself. Quick point, your comments in relation to patient advocates is spot on. Demographically, it's impossible to get the appropriate people to sit, the two people to sit on all of these groups unless they are going to have some form of recompense for their time off work. You will not get people of, dare I say it, my age or younger to go on because they can't afford childcare, everything. That needs to be dealt with. I think as a committee, I think we should just advocate that. We're not going to get to this, but the ORCOG review will not deal with the question I've asked as to why the labs were not investigated as part of their contracts when there were issues found. That needs to be dealt with somewhere. In fairness to you, you've said the quality control was effectively a joke, that it hasn't happened since 2014, and actually we even don't know what was going on or who was accountable. All of that needs to be encapsulated somewhere. It's a big chunk that I feel is missing. I think it's no one's fault. I just think it's missing. Right? My questions relate to the following. The follow-up you're going to do in relation to the labs and the outsourcing. And your commentary, and I've read it in detail in the report. Are you confident that there aren't other locations and other labs that some of these labs may have outsourced to on top of what we know now? In other words, is it limited to just those? I'll throw through my questions and then you can come back if that's all right. Okay. Because my second question then is, as regards accountability, I have no confidence in the HSE investigating themselves. And given the data that's in it, as regards accountability, there has to be some form, and I believe, Dr. Scally, it'll involve you. I believe it'll have to involve you in a second phase as regards accountability for what we just spoke about in relation to quality assurance, in relation to contract management. And I'm with you in relation to the people working down in Limerick in actual CervicalCheck, because I think they're not the issue here. It's a higher up the food chain. Second question. Third question. The audit, and this has often been missed, Chair, the audit has stopped. So what are the consequences of that? The audit has stopped. So are we going to have a delayed problem here? If everything is said the same, the parameters have said the same, etc., 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 are we going to have additional issues regarding women potentially not knowing information? And obviously, given that the audit has stopped, there won't be disclosure. And how's that going to be done? This is a live issue today. And final question, my fourth question relates to another live issue. How are we going to deal with the fact that slides, given the commitment given by the Minister, which, to be fair to him, and I don't want to jump down on him, to be fair to him, he's actually probably admitted what may have been a mistake. The fact that slides are now going out of date, and also that women are having to wait so long for their smears. They're my observations on 4 questions. Thanks.
Okay. Thank you. Other labs, I'm not in a position to provide you with any reassurance about that. It is an issue of concern to me, and we will be pursuing that with rigour. And by the time we come back with a report, I hope I will be able to reassure you. But I would not rule it out. I would not rule it out.
Mexico has been spoken about.
I think, well, the mention of Mexico is an important part of this whole story, because there was a rumour circulating about Mexico for some time amongst the cytopathology community, and we don't believe that there was any use of laboratories in Mexico.
Nor do I. I heard the same rumours.
But we understand how the rumour started now, because of the facility in the laboratory in San Antonio, close to the very close to the Mexican border, and with staff at the head of it who were of Mexican-American origin. So we can well understand how.
So we just don't know. We'll find out into the future where.
Rumours, yeah, about the labs. About carrying out the investigation, I share your sentiments about HSE. I am, however, as I said earlier, I am optimistic about the appointment of the new chair of the board, and I hope there is appointment of board members soon, and I would look to that board to make sure that a proper investigation is carried out. I think that's the correct place to start, and they should have the independence, the control as a board to make sure it happens. If I was interacting with that organisation in my context, that would be part of my discussion with the Minister and the board members, that I would want that to happen. Audit has indeed stopped. I'm not sure what the way forward is. We've got this time period now to the implementation of the new system, and a system audit will have to be designed for that, and we will have to deal with this issue. And it's not clearly part of my report, but you're quite right in pointing
this will cause additional problems
as an issue.
On the law of averages, it will.
We just didn't answer the question.
I know.
And as for slides and the issue of them going out of date, Dr.
So at the moment, the existing providers are unable to cope with the volume, which is resulting from all the additional uptake of samples, and it is in excess of what they're contracted to do, so it's not really surprising that they can't cope with volume. And that is resulting in backlogs, long backlogs building up, and those backlogs will continue to increase as long as the number of samples carries on at the current levels. I think there is very little that they can do to mitigate that, because one thing they have learned from this is that it's not a good idea to send them out elsewhere. So it is a real problem. Now, the cervical cytology slides themselves don't really have a problem with lifespan. They will last for plenty long enough to allow them to be properly reported. The problem comes with the HPV testing, which is currently undertaken as a reflex for certain grades of abnormality, and that does have a lifespan on it. So I think probably getting quite close to the point now where some women may not be able to have the reflex HPV test because it's out of date. So it is beginning to reach a critical point in terms of the laboratory process, but of course in terms of the woman's experience it's already critical, because a lot of them are very anxious, understandably, and they're waiting for a very long time for their report. So I think it is a genuine problem, which I'm afraid to say is only going to get worse if no action is taken.
What type of action? What type of action, sir?
Well, I mean, one of my other concerns is that, unfortunately, the women who are actually due for a sample, who are at greater risk than a woman who perhaps had one quite recently, they're also getting stuck in the backlog. So it is actually disproportionately disadvantaging the people who are actually due for a test, and that will include the people who are not what we would call the worried well, who are, the ones who we really want to engage in the screening programme. So, I mean, it's not for us to say, I don't think. I think all I can do is point out to you that the current volume is unsustainable. Implementing HPV primary screening would solve the problem very rapidly, and one of the things that I jotted down that I just wanted to get in at some point was to say, this is just really urgent, and I don't know what the timescales that are currently being worked to are, but I think it really is a case of the sooner the better.
Thank you. That's very helpful.
Deputy O'Connell.
We spoke earlier about the counselling or the information people got when, or any of us got when we went for a smear, and this idea that when you had a clear smear that everything was fine. But in your report, CervicalCheck are the people that organised the training, so surely they're at fault for the bad training because it is in the report. I mean, the big concerning thing for me is that I would have assumed before any of this started that CervicalCheck checked slides. I just assumed that. I would have assumed that there was a lab somewhere and there was people in it checking slides. So we have doctors taking the smears, or nurses in the community. We have labs abroad testing the samples. And then on page 26 of your report, you have the organisational structure for the people. But if someone was doing the testing and someone was doing the screening, the people on page 26 just seem to have been administering a service. Because if they only had one meeting in 10 years, and if nobody was joined up, they just seem to be, they don't really seem to have had any proper role. And like you specifically say about, you know, that nobody was in charge. You say it twice in the early part of the report. And one thing that concerns me is that in January 2014, the NSS moved into the Directorate of Health and Wellbeing. I just can't see why that happened. I can't see any logical reason for why that happened. And I can't see it in the report. Maybe you could point me to, or if there is a reason. Obviously, this idea and the job description, although it's a funny anecdote, it's so serious that even in the smallest of businesses, you're required to have a job description. And, you know, it's very easy, and I worked myself in the NHS, it's very easy, you know, to make sweeping statements, oh, the NHS is dysfunctional, or oh, the HSE is dysfunctional. But I think here we have right in front of us a prime example of an arm of the organisation that is exactly as bad as we could imagine. On page 29, there's a reference to the recession. So I'm just wondering, was this the only excuse for incompetence that was offered to you? Because it seems like a fairly weak excuse. On page 30, where am I looking now? Yes. The QA committee had a number of subgroups that concentrated on development of standards for key functions in the screening process, such as cytopathology, primary care, histopathology, colposcopy, and administration. Was there some reason why screening standards weren't included in that? Or am I missing something? Then I want to know, is there anything, on page 32 there's a comment from yourself, it was clear that all was not well in the screening. How do we know that? What evidence do we have? What did you base that comment on? And do we know anything as to why CPL just stopped in 2013? Do we have any reason why that decision was made, other than perhaps financial? And then there's the concerning comments on audit. So I think on page 35, yeah. The bottom of page 35, this is difficult to understand as the audit process commenced. So their comment, clinical audit process established and embedded in CervicalCheck by 2017. But they started talking about it in 2009. So, like, it looks like people were just making forms, creating SOPs, having meetings, and basically doing nothing, to my mind. You did ask, and maybe you didn't want an answer, you can't understand why we had an 8-year pilot or why it took us so long to roll out HPV. But if you look at the media around that time, we're coming from a very primitive background in this country when it comes to women's health. And if you look at the media surrounding the rollout of the HPV vaccine, or the HPV vaccine, but also screening. I mean, we've had comments about, you know, you wouldn't need, by some religious organisations, that you wouldn't need HPV if you led a pure and chaste life. Tends to be a fine thing, but, you know, that is the answer. There was huge pushback when the Minister for Health at the time, Mary Harty, brought in the cervical screening. There was terrible connections made with lifestyle. And then when it came to HPV testing, we had a huge pushback from whatever we want to call them, interest groups, I'm not sure, destructive people that caused our vaccination rate. So I think our primitive attitude to women's health is probably the answer to the question that you may not have wanted the answer to. But I think we're starting to catch up now, albeit very late. I'm just very concerned in general about how there was this arm of the HSE with all of these people who all had jobs, job titles, who were all getting paid big money by looking at the wage bill. And yet, and some of them were eminently qualified people, so they weren't just, you know, people off the road that came in. Like, it just seems like such a basket case of an organisation that they couldn't even manage their data right. That's me done.
Yes. I'm having difficulty disentangling the questions from the observations. And,
sure. Do your best.
I'd be very happy to respond to some of those.
Normal enough, yeah.
To respond to some of those in writing, if you like, in detail.
Yeah.
Undoubtedly, the budgetary. When you look at the budgetary profile of CervicalCheck over the years, it's not satisfactory. Really, in terms of financial management, and money was removed from CervicalCheck and moved elsewhere, and it's very difficult to see why. And the absence, as you correctly point out, which I've commented on, the absence of someone being in charge of CervicalCheck and being a champion for CervicalCheck is a notable absence, I think, in the whole thing. The QA subgroups. This was the QA committee of CervicalCheck, if I've got the page right. Yes, page 30.
Yeah.
So it's the CervicalCheck Quality Assurance Committee, and they did have subgroups looking at these issues. But my point was that you would have thought that they would have had some engagement with the development of the review and the audit and the 7 iterations of it, and they didn't. And it came as having talked to people engaged with that committee, and they were very surprised that all this had been going on somewhere else.
Parallel.
And that they hadn't been involved with it. Clear. I thought it was fairly clear about things not being. When I said there was appreciation that at the top of the HSE that all was not well, mainly because they engaged an external consultancy company to do a report on it, and when you look at the findings of that report, the one I quote in particular continues to be a somewhat negative relationship and clear disconnect described by the programmes between themselves and HSE, chain of command, issues of isolation, suspicion, lack of trust or support, and poor or non-existent communication were cited. There was clearly some understanding that things were not going well.
That's what you mean, the organisation?
Yes.
Right, thank you. Yeah.
CPL stopped in 2013. We are looking at all the contracting and procurement issues as part of this, I hope, final bit of our work. So I'll be able to give you better answers on that when we've done that, if I may. Oh, yes. Yes, can I just ask Dr. Denton to explain some of the background to the changes in the laboratories? Yeah.
Yes, so CPL is part of the Swanick group, and part of the reason it was actually a planned transition to using MedLab pathology, which was a newly established subsidiary also of Swanick, which was established in Dublin. So actually, from Swanick's point of view, the move from CPL to MedLab was planned, and that was part of a long-term strategy to repatriate the work that they did for the Irish programme.
Thank you.
Deputy O'Reilly.
Very much. I have a very quick question. On page 59 of the report, you refer to the accreditation. I find it, I actually do, as someone who uses the service, I find it outrageous that we're only asking these questions now. But my understanding is that yourself, Dr. Denton, you're going to do a comparison between what the CAP accreditation would be. Did I hear you correctly, Dr. Scally, when you said that? What the difference between the CAP and the ISO? Okay. A little bit like, and this is no disrespect intended to yourselves, but it's a bit like shutting the stable door after the horse is bolted. We know that.
Well, indeed, unfortunately, I had no control over the stable door.
No, I fully respect that. But my question is just in relation to a line in the report. It says both laboratories do have CAP accreditation, which they view as being equivalent. Is it written down anywhere that people in the HSE viewed it as equivalent, that anyone in the HSE or the CervicalCheck service actually bothered to even run the slide rule over it to see if it's the same, or if it's equivalent, or if it's different, or if it's substandard? Because I mean, without a time machine, you know, there's very little we can do if it turns out to be substandard. But it's very disturbing that people in very senior roles within the HSE and the screening programme appear to be not bothered in the slightest about the accreditation. Did you find any evidence that even when they visited, that they didn't ask to see? I worked in a company years ago, we got ISO 9000, I think it was, accreditation. The books and the manuals and everything, what you have to go through, please just stack it up that height. With any evidence of that at all? Anyone asking a question, or were they just signing a cheque at the end of the year?
So I think one of the things about the quality assurance visits is that they didn't have a protocol. They didn't have sight of the procurement specification. So they were looking at a series of things that they thought needed looking at, but I don't think that they were possibly even aware of the accreditation requirements, and that's why one of the recommendations is around ensuring that there's a clear protocol for quality assurance which reflects and references what the contract specification is. Yeah. So in terms of so I just wanted to put that in about quality assurance actually and its impact on
I think your observations may well be proven to be absolutely spot on, and we will be reporting on that very issue. Okay. I've seen no evidence to date that would satisfy me that the questions that should have been asked were asked.
Okay. So, and just to be clear then, the slides that might go today, nobody has looked in the intervening time with the, everyone in the media focusing their attention on this with all of the outcry, and in particular given that we all know what's happening today, and that is going to put a focus on it. Are you saying that nobody in the HSE has begun, or in the screening programme has begun the process of even looking at what the CAP accreditation means and how it might translate to ISO? Or
so I can't answer whether they've started looking at a comparison, but they have certainly started looking at trying to ensure that ISO accreditation is gained by these laboratories. One of the challenges about that is that, as you point out, it's a very hefty documentation process, and it is also the pace of accreditation is controlled by ISO. It's not a quick fix, and it will take some time. Even if they put their application in today, it will still take several months before they would have it granted. So there is some action.
Okay, but there's no scope for us then to recoup any of the money that was given, because the contract was signed on the basis that the lab would be ISO 15189 accredited. No, do you understand?
I understand your concern.
That I get people coming to me in my office and they ask me, can you have faith in the programme? And I tell them, absolutely, screening saves lives, 100% it does. I have seen it with my own eyes and I know that it does. But when you see, given what we're here discussing, given the fact that that there has been an awful lot of attention, that even at this stage they're only moving now to, and they have no control over these US labs. They can't compel them to, the mechanism that you would use to compel someone to apply a certain standard is to say, well, I will withhold that contract until you demonstrate. Now, clearly the HSE haven't bothered to do that, so that hasn't happened. These lads are still getting money for providing the service, but nobody quite knows. And you might very well be right. It could be, that the CAP accreditation is the same as the ISO accreditation, but that's not what's written in the contract.
Correct.
And nobody
we will be exploring that, and we'll also be exploring almost the identical issue in that the contract, for example, with CPL was for Austin. It wasn't for San Antonio, it wasn't for Honolulu, it wasn't for Florida. Exactly. The contract actually specifies Austin, and we're having some discussions about what the terms of that contract actually mean, and we will, I suspect, have to take legal advice in terms of the contracts and if there are legal implications in terms of both of those areas.
Yeah, it is an awful pity that nobody was looking at that.
Of course, it should. It is. I find it astounding that there isn't a trail of documentation around both of those issues. And if they were going to accept CIP as equivalent, there should have been a document trail.
But they should have determined it was equivalent, and they haven't.
And we have yet to find anything.
And has anyone, sorry Chair, just one very last question. You've talked to a lot of people, and I understand there was issues getting documentation out of them, and believe me, as someone who dealt with the HSE, I was that soldier. You could sing it if you had an ear to it, and I know sometimes it can be difficult to get information from them. But in the course of your discourse with them, did you get the impression at all that it was anyone, I know they didn't have job descriptions, but was any hero taking it on to, look at the contracts or monitor them in any way, shape or form, or monitor compliance? But they fell at the first hurdle. The contract says ISO, and
I have concerns about that whole area, which is why I've said I don't want to comment. If you'll excuse me at the moment.
No, that's fair enough. That's fair enough.
But I share your concerns.
Yeah.
Was any evidence that it all started that there was labs tendering for the work that were ISO accredited, and whenever 10 years ago? And so do we have any idea of the basket of tenders that came in for the job? Or did you find anything, and did you find anything that showed that this decision to go with the potentially less effective? Is there any evidence to show that a decision was made to go with the CAP rather than the ISO? Did someone actually not read them? Have we any evidence?
I am concerned about that original tender process, both in terms of the way in which it was conducted and the way pre-tender discussions were had with laboratories who might have wished to take part in the tender but didn't.
That were ISO accredited.
Or potentially, or very nearly ISO accredited. But we will be exploring that issue. You touch again on...
And sorry, so just finally, so the first thing in the contract, and as I spoke, I think when Louise was out about this, and she follows on, and then the ISO accreditation, but also within the contract, my understanding, is it clause 39 or something, I can't remember what it is now off the top of my head, that really this facility for subcontracting out or giving away slides was kind of if your plant went on fire. It wasn't, that's my reading of, I've looked into it, and my reading of it, the clause was there, you've got 1,000 slides coming from Ireland, your lab burns down, so, I think it's clause 39, it states that they can send them elsewhere in the situation where basically a disaster happens. And it's under that line that they're saying they could send them to Honolulu or wherever they sent them, which to my mind is breach contract, to my mind, and then obviously this ISO element. So there's two very critical points in the contracts that, to my mind, are very serious.
Any rational human being would think exactly along those lines, and I thought exactly along those lines. There is, however, something else in the contract which indicates that the headings on those subsections are not to be taken as part of the contract. Now, this is something we will be exploring.
Just to clarify, one clarification. Earlier on we spoke and you said that the actual contracts had been shredded. Yes, the tenders. I think it's the tenders that we... all the tendering documentation has been shredded. Yeah. Obviously all the contracts you have. All the contracts.
The contract, yes. The ones that are in place, yes. I think that's correct.
No, just to clarify, have you all the contracts that have ever been signed?
I believe so.
You believe so?
I'll confirm that to you.
Okay, but just for the committee's use, can we find out, because I understood we have, but I'm concerned now, that you have access, because I asked the question at the beginning, were you given access to everything? Have you a copy of every single contract or subcontract that has been ever done with any lab?
I believe so.
That doesn't...
Well, the reason we're carrying on doing this work is because we're not yet finished it, and we're reconstructing a back trail which will take us, we hope, to enable us to reconstruct the whole tender process and contracting process, including the call for tenders. The tenders went in, and we will also be exploring those who didn't tender and might have tendered, if you understand.
Yeah. That's all good.
And as far as I'm aware, we have been given access to all the contracts. We had some discussions about it in terms of some of these matters might be commercial in confidence, and I think we resolved all of those satisfactorily.
Surely the HSE would have access to be able to tell you that they've handed over all the contracts.
Yes, and I will tell you.
But you don't know yet?
No. I believe we have. But when you ask questions, you ask them with a purpose, so therefore you make me uncertain of my certainty.
Lovely fella. Can I just ask you in relation to the National Cancer Registry, have they actually exchanged and given all of the relevant information now and shared between CervicalCheck, and is that issue resolved?
Yes, I believe so.
All of the documentation that they...
About the cases, yes.
Yes, but all of the documentation that is relevant in order to have one kind of, I suppose,
yes,
platform of where all the information is on.
Yes.
Okay. The second issue that I wanted to check with you is about, going into the future and the issue now about engaging with labs. Obviously, labs in any contract negotiations now are going to look for, I suppose, new terms and new conditions, in particular in relation to dealing with the issue of litigation. Do you think that will now pose a problem going into the future from what you've gained over the last 4 to 5 months in your work?
Well, again, it's not entirely part of the scoping inquiry's work, but I think it's pretty obvious from the from what we know about the discussions that have been going on, that issue is a central element in the contracting, and I very much hope it will be resolved, because we absolutely need to continue the programme for this next 12 months at least, or until the HPV comes in. So I'm not privy to those discussions about liability, but I do hope that they're
you
resolved.
do believe it is going to be a problem?
Well, from the reports that have appeared about those discussions, it does appear so. Okay. But I'm sure I'm no better or worse informed than many around this table on that issue.
Yeah, sorry, Deputy Durkan.
My hand up a long time ago, Chairman.
Sorry, my apologies.
I won't suggest anything. I know that sometimes the right-hand side of the difficult to see.
It's not a
peripheral vision improvements are needed. But however, two questions come to mind. First of all, Dr. Scally made an interesting reference a few minutes ago in relation to the chain of command. This is something that we have raised at these meetings on many, many occasions. Is there a chain of command, is my question. And to what extent does it work? I used to be a product of the old health boards. In the health boards, there was a programme manager who was responsible for a series of issues and protocols, and was held responsible for it on a regular basis. I believe that's disappeared. I don't think it exists anymore. The other question that comes to mind is, and reference has been made to it already, in relation to tendering. I used to be a kind of a half expert on tendering once upon a time, in a different capacity as well. Can I ask, to what extent any visits took place to the labs who were likely to tender, or were all labs visited, or were the terms of reference set out in the tender documents such as to ensure that all possibilities were catered for in the future, including the issues about ISO standards, etc. And could you whenever I see tendering, I always get uneasy. It's a feeling, Chairman, that has affected me many, many occasions in the past, and I just wonder about that, whether or not there are grounds for optimism in relation to the tendering process, how it has gone about, who actually promoted it, who was in charge of it, how the tenders were open, were they open in public, and whatever the case may be, and all that. So if you would like to comment on it, maybe perhaps.
I don't have answers on those points, as you understand, but they are valuable points, and we will include them in the piece of work that we're doing. And it is important. It is important that they are answered.
If I might briefly.
Yep.
Australia has HPV testing and has rolled out this very successfully, and they're in line to eradicate cervical cancer within the next 10 years. How quickly did they roll out their HPV? So how quickly, in an international context, has it ever been done to change from A to B, screening to HPV? How fast can we do it once we don't let the lads that did it before do it?
Australia went from a decision to implement to actually implementing in about 12 months. However, I have to check the exact duration, but it was of that sort of order. The UK, or England at any rate, will probably take about 18 months, Scotland and Wales somewhat quicker. So, but obviously we're not starting at the point of making a decision. A decision has already been made. So I think implementation within 12 months is achievable.
Thank you.
Could we finish it at that? And could I just thank Dr. Scally, Dr. Fenton and Ms. McEntee for their contributions here this morning, and thank you for the very comprehensive report that you've given to us. And I suppose it also sets a very high standard for future reports, no matter what the inquiry is into the future. I think it shows how a report should be done and how an investigation should be done. I think it certainly set a clear template as regards how future investigations, no matter what area they touch on, should be dealt with, and how it was subsequently then dealt with in getting the information out to the general public. So again, thank you, Dr. Scally, to Dr. Denton. Thank you for your contribution, very valuable contribution, and Ms. McEntee here for being here this morning and for giving so much of your time. And you're here since 9 o'clock, and we very much appreciate all the information that you've given to us and the honest way in which you've answered the questions.
Thank you very much.
Thank you.
Sorry, could I just ask members to wait for we just have about 2 or 3 things that we need to get off the agenda.
Suspend for a minute, sorry.
So could I suspend for 1 minute and...
Yeah. Thanks, everyone knows.